to our April meeting. Before we kick off today's meeting, I have a few housekeeping items to share. Please, if you're a board member or OHS staff, display your name on your caption so we can see who you are. If you feel comfortable, please feel free to share your video if you're OHA or a board member. The chat feature only allows you to communicate with OHA staff. Any comment should be mailed to Oregon Health Policy Board at healthpolicyboard.info@state.or.us. That's healthpolicyboard.info@state.or.us. To make this publicly available and improve transparency, this meeting is being recorded. So with that in mind, Steph, would you do a roll call, please?
I'm going to pinch hit today for Steph. This is Tara Chetok, Project Manager of the Oregon Health Policy Board, and I'm going to go ahead and call roll. I see most members on, but to make it official, Oscar Arana?
Present.
Thank you. David Bangsberg?
Here.
Ebony Clark? Okay. Kristen Isaacson?
Here.
Great. Brenda Johnson?
Here.
And John Santa.
Here.
Great, thank you.
Today, for our meeting, we'll have an update from Director Allen, legislative update. We'll also introduce the draft framework for monitoring the cost growth target program. We'll have a 10-minute break. And then we'll hear from the Health Equity Committee regarding an updated health equity definition for the state. The last portion of the meeting will be dedicated to the waiver updates from the Oregon Health Authority leadership team. Please note that the materials for this board meeting are on the website. I'll also direct you to the committee digest, which is a quarterly digest of all the Oregon Health Authority, Oregon Health Policy Board subcommittees, and an update from each committee. So please check that out. And we will continue to share that the first month of each quarter. So our first order of business today is to vote and approve the minutes. So I hear a motion to approve minutes.
So moved.
Do I hear a second?
Second.
All in favor? Aye.
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 Any opposed? Any abstain? Okay. The minutes are approved. Director Allen, what has been going on this month? What do you have to share?
Well, we've got this.
The order.
So we got this pandemic going on. You've maybe heard about.
Yeah.
I'll give you a couple of just a little bit of an update on where things are there. The main news right now is that Oregon is one of about 30 states that's seeing an increase in cases. It's interesting. The states that are not are largely those that have previously been very hard hit. At some point, particularly very hard hit during the fall and winter increase in cases. And so we're in with a number of other states that have done really pretty well through the pandemic. And the increases we're seeing right now are with the wrong direction, but from a relatively low baseline level. We got down to about where we were in September of last year. That's still not what I would characterize as low in absolute terms. Back in September, that level didn't feel so good. But this is the first time we've had a peak where we got back to a pre-peak level, as opposed to just going up, coming down partway, and then building up again to the next peak. So I'd rather be where we're at now. Now it's easy to see these increases and think, well, that must be the variance, and that could certainly and almost certainly is part of the picture. But there are actually a lot of things going on right now. We had much of the state move out of higher levels of containment in our risk structure, including the Portland metro area moving out of the extreme category into high and then moderate. And that's been a number of weeks ago. We've got increasing numbers of kids coming back to in-person education, and importantly, doing the other things that go with that. Sports and clubs and out-of-school activities and those kinds of things, which appear to be an actual place where there's a fair amount of transmission as opposed to in classrooms. We have the vaccines that are arriving now, which gives people, I think, an increased and in many cases unwarranted sense of safety. Knowing that some small number of other people besides you are vaccinated is not the same thing as getting to a level of herd immunity. That also ties in with the notion of kind of cycles of people being concerned about high levels of cases, and then cases go down and people get less concerned and they're less vigilant in their protection. So I think all of those things are really at play right now. We certainly do have variants present and likely increasing in the state. You've heard a lot about the B.1.1.7 variant first identified in the UK. Once CDC identified a couple of other variants as variants of concern, we released numbers on those, and they actually are quite a bit more prevalent. It's the B.1.427 and 1.429. These are both variants first identified in California, although I think the lineage actually goes back to Italy. We are now able to do our own sequencing at the state public health lab. Right now, the capacity is about 100 samples a week. It is still a time-consuming process to be able to do that sequencing. We're working to build that capacity that'll help us have a better sense of what we're facing. At the end of the day, though, the things you do to control variants are more or less the same things you do to control the coronavirus generally, which is wear masks, avoid large crowds, wash your hands, all the basic protective actions are the same ones that work with the virus and with the variants. In terms of vaccination, the big news today is the governor announced that we're moving the eligibility date for all Oregonians 16 and above from May 1st to April 19th. So we'll have about a 2-week window to work on the remaining targeted populations and then move to everyone at that point. The pace of vaccination continues to increase pretty substantially. Right now, we're averaging about 34,000 doses a day being administered statewide. That's up from about 27 or 28,000 just 2 or 3 weeks ago. So those numbers continue to build substantially. We're going to face some challenges in maintaining that pace due to the manufacturing error for Johnson & Johnson back in Maryland, where 15 million doses were spoiled in the manufacturing process. And so this week we have about 60,000 doses of Johnson & Johnson available to be administered that we expect will drop to 0 next week. And we don't know when that supply will be reestablished or if there'll be a lower supply at some point before building back to that larger amount. In terms of vaccine equity, we are beginning now to see some improvements. I think based on some of the strategies we've put in place to address that equity. Right now, if you look at percentage of vaccine, where it's going, there are several ways you can look at equity, but if you look at where vaccine is going, we're ahead of the curve for the Native American, Alaska Native population and for the Native Hawaiian Pacific Islander population. We're a little bit behind the curve for the Black African American population and quite a bit behind the curve for the Latina population, but moving in the right direction. As of say a month ago, only about 4% of vaccine had gone to that population. That's now up over 6, approaching 7. So directionally, that's headed the right way. We continue to allocate vaccine to federally qualified health centers, and we've expanded that program now to all FQHCs. Not all serve that community, but many do. And we've for quite a while provided them flexibility to basically vaccinate their entire patient population, regardless of where they are in the prioritization process. I think that's about it on. And one last thing on vaccine, we have raised some concerns about whether Oregon is getting the doses that it should. We have a meeting later today with the White House to dig into this. Basically, if you look at per capita allocations or per capita 18 and older, we rank, depending on what you look at, somewhere between 40th and 50th in the country for the doses per capita that we get. And there are reasons that may be a completely appropriate number. For example, the highest state in the country is Alaska. Also up there are New Mexico, North and South Dakota, Oklahoma, and those are all states with a significant tribal presence. And there's a special allocation that goes through Indian Health Service to tribes, and so that's pretty easy to explain. States with a large military and VA presence, same kind of a deal where there's an over allocation. But there are other places where we look, Vermont or Maine, for instance, that are getting substantially more doses than we are, and we can't explain that. So that's the purpose of the meeting today with the White House, is to see if we can dig into that and get a better understanding of those numbers and see if there's a concern or not. I'll just quickly, only other thing to touch on quickly is legislative session, which continues to kind of move apace. We completed our budget presentations a bit ago, and we're now into more concrete discussions, particularly around the Medicaid budget with a legislative work group. Our bills are largely moving. You'll hear more detail about that from the government relations team. But all things considered, from our standpoint, the session seems to be moving fairly smoothly. I think it's really going to be a question of are they able to, continue to do business and move bills and do floor sessions and those sorts of things. So I think I'll go ahead and stop there and see if anybody's got any questions.
Any questions from the board?
Question regarding the funds coming from the American Rescue Plan and how that's going to, affect OHS budget, and what you're thinking about how that'll be utilized.
Yeah, I can say a little bit about that, and probably we need to come back and do a more formal presentation on it at the next meeting if you'd like. We're still trying to get a good handle on exactly how that money is going to flow to us. Is it going to flow programmatically through the usual funding sources that we get, especially but not exclusively in public health? Is it going to be like previous funds have been, where it gets allocated to the state and the legislature and the governor to determine how to invest it? But as I understand things right now, a lot of the funds appear to be flowing in a way that's pretty consistent with what we've been referring to as public health modernization. So plussing up the foundational functions that you need in a pandemic, but you need beyond a pandemic as well. And so our general intent is to first use an equity framework to determine how to invest those dollars when we get to actually spending them on the ground. But most importantly, identify how to use that money to build something better, so that when those resources are gone, we have a better structure, a better way of doing business, and increased capacity at both the state and local level to deal not just with the pandemic, but the next pandemic and the ongoing, chronic diseases and communicable diseases that we currently deal with.
John?
Yeah, Pat, I just wonder, while I think it's terrific that demand appears to be robust in Oregon, you can certainly see with the seniors that demand has dropped off. And I'm wondering, if I suspect that there's planning going on about how to manage, the hesitancy issue, and, try to promote more demand. I see the discussions going on, especially as private companies realize that there could be demand among their customers to be as safe as possible, and want to be assured that vaccination has occurred in employees or other folks. Again, in my 70s circle, certainly our friends are saying, I don't want to go to a practice that the employees aren't all vaccinated. I wouldn't want my father to be in a nursing home that the staff aren't vaccinated. Any information on where you all with those sorts of issues?
Yeah, so you're exactly right. We're approaching about 75% vaccination for all populations 70 and older. But those numbers are beginning to kind of level out. Now, nationwide, the vaccination rate for people 65 and older is somewhere between 70 and 80% in most states, with a few outliers. So we're kind of in the middle of the channel right now. Our statewide average is just almost exactly 70%. Of concern, 65 to 70-year-olds seem to be topping out at about 65%. And that's not at this stage through lack of access. There's been plenty of opportunity. I mean, there are people who are, hard to reach who have had struggles, but at this stage, though, there's been plenty of vaccine available and opportunity to get vaccinated. So there's some hesitancy, or sometimes I refer to it as obstinacy, I think, going on there that's affecting that. And there's also a pretty marked geographic split. Where you see metro areas in the valley with higher rates of vaccination than more rural parts of the state, where some of the numbers are really alarming, topping out around 40 or 45% of seniors getting vaccinated. So we are working on a variety of communications efforts, including one that's sort of targeted at rural seniors, to try to work to get them vaccinated. Honestly, we know that one of the best voices for those people is their healthcare provider. And so, one of the big keys will be when we get enough vaccine to get to the point, and which we're approaching now, where, you're not going to a convention center or a drive-through tent or something, you're going to your doctor's office. And your healthcare provider can then have the one-on-one conversation to say, well, I've gotten vaccinated and here's why, and here's what you should know about it, and all those kinds of things you have in that patient interaction. There was another part of your question that I've lost track of, John.
Well, employees.
Right.
Yeah, we vaccinated healthcare workers for hepatitis B. We vaccinate healthcare workers for flu. I don't have an older relative alive any longer, but my dad was in assisted living for 7 months. I would just be so concerned if the staff in his assisted living place weren't getting vaccinated. And
yeah, we're working together with DHS on some approaches around that for how to improve the vaccination rate of staff in long-term care. Some related things about getting newly admitted residents vaccinated, getting people vaccinated on hospital discharge, and those kinds of things. We're really focusing on the staff. Even in primary healthcare, the same geographic split is showing up, that healthcare providers in more rural parts of the state are getting vaccinated at a much lower rate. It's really puzzling, even in hard hit parts of the state where, in their hospitals, they have seen capacity issues and seen patients dying, and still relatively low percentages of people getting vaccinated. So that's also a push that we're trying to work on. But the regulatory tool really is particularly useful on the DHS side, where they've got oversight of the non-nursing home facilities.
Any other questions? Well, thank you, Pat. Appreciate the update. For those attending the meeting, you can see also the COVID update in attachment 2 on the meeting materials. Before we go on to the next agenda item, I just want to check with, there's a few people on the phone who want to check to see if Ebony Clark joined us. Ebony, are you on the phone?
Yes, I'm here.
Oh, great. Okay. Great to see you. All right. Our next item is government relations legislative update. We're have the pleasure of being joined by the government relations team, Jeff Scrogan and Angela Albee, both senior policy analysis analysts with OHA. And we'll be doing a government relations or legislative update each meeting while we're in session. Slides for today's presentation is in attachment 3. So Jeff or Angela, we'd like to take it from here.
Yeah, thanks, Dr. Bangsberg. Can you hear me?
Yes.
Great. Thanks for having us again. Just to give a little more context, we came last month and we kind of focused on behavioral health policy and equity. And this month, we're going to focus on public health policy and equity. So we do have our slideshow here. This slideshow looks very similar to last month's, but I'll go ahead and go through it and orient it to you. And I'm joined by my colleague, the Senior Policy Advisor from Public Health, Angie Albee. Next slide. So This is our health equity definition that the board decided and voted on. I think I saw on your agenda that you're going to be taking a look at this later today. So we'll have to see if we need to update it for our next meeting. But this is the definition as I understand it. And our agency's strategic goal is to eliminate health inequities by 2030. Next slide. This is the government relations team. You'll recall we had most of these folks come visit with you in the beginning of session. Holly Heiberg is our government relations director, and I expect that she'll join us at our next meeting next month to kind of give a comprehensive overview of how the session is going and where we are with the timelines. Next slide. This is an important slide, one that folks who are working this session are turning back to often. This is deadlines for the legislative session. This is kind of how you can see bills move through the process and stay viable or not stay viable. Almost all bills are subject to these deadlines. There's a couple of bills that are in key committees. Those committees are not subject to some of these deadlines. Committees like revenue or rules. So if you hear of a committee in one of those, or bill in one of those two committees, it may not be subject to these rules. The bills that are really, really affected by these rules early on most, or these deadlines, are the bills that are in policy committees. So in Senate Health and House Health and House Behavioral Health and Senate Mental Health, that all these deadlines apply. You can see that the first deadline has already passed. This deadline was to schedule bills for a work session where they can be amended or voted out. And then the next one is coming up here just next week, I think next Tuesday, April 13th, the deadline for work session in original chamber. And that kind of builds on the March 19th deadline. But it means that not only does the bill have to be scheduled, it has to have been worked. It has to have had that work session that it was scheduled for by April 13th to remain viable. So when you go on the Oregon Legislative Information System and look up a bill and look into the history of it, if it's in one of these committees, not in rules or revenue, and it hasn't had a work session by April 13th in the chamber it started in, then it may no longer be viable. Next slide. These are kind of the three big buckets that we organized our bills into. We brought this to you at the start of session and last month when we were going through them: improve behavioral health services and decrease behavioral health inequities, reduce barriers to health and reduce health inequities in our communities, and reduce health inequities in the healthcare system and realize better care, better health, and lower cost, the triple aim. Next slide. So last time we focused on these first two slides regarding behavioral health, and we're not going to focus on them this time. Can you go forward one more slide? I'm going to turn it over to my colleague Angie, the Senior Policy Advisor from Public Health, to kind of walk through some of the public health focused pieces of legislation for OHA now. Angie?
Thank you, Jeff, and good morning to everyone. Thanks for asking me to come and talk about public health bills and policy option packages. I think we'll go ahead and get started. You'll see as we move down, there's the ban on flavored tobacco sales. I think all of you probably are aware that Governor Brown pulled together a governor's vaping work group, and a number of policy recommendations came out of that discussion. And there were a number of recommendations, but two of those we actually introduced concepts this session. And one of those had to do with the banning of flavored tobacco sales. And so that was House Bill 2148. That bill is not moving this session. We will have most likely an informational hearing towards the latter part of session, just to discuss it and potentially frame it up for a future discussion in a future session. I think because of, working within a global pandemic, a historic wildfire season and other issues, it's been really difficult to be able to put all of our energy into a number of tobacco policy bills this session. So a lot of the stakeholders really wanted to focus on actually passing tobacco retail licensure, which I know we've been trying to do for a number of years. And so I'm excited to talk about that next, which is tobacco retail licensure. We introduced House Bill 2071 this session. And similarly, Senator Taylor and Representative Salinas introduced Senate Bill 587. And the decision was made that Senate Bill 587 would be the vehicle this session. but that we would all work together closely to ensure that we were able to go through, get over any obstacles and really have a robust discussion. The good news is that Senate Bill 587 has passed out of Senate Healthcare, and initially it had a referral to Finance and Revenue, but that was rescinded upon passage in committee, and it's now been referred to Joint Ways and Means. So this is one of the bills that is now sitting in Joint Ways and Means, and will be worked kind of when we get to that point in session. All of that said, it's just a couple of highlights because I think this bill is really important, is that in previous sessions, we specifically last session, regular session, we did some work around what a good policy would look like for all of the stakeholders. And we came to a really good agreement about the fact that we wanted to ensure that if a county had already, introduced a tobacco retail licensure program in their area, that we could still work within that framework to ensure that we could create a statewide licensure program. Another piece was that there were large pharmacies that actually didn't want any kind of prohibition from selling tobacco products in those larger pharmacies. And although, many of us really wanted to ensure that, that wasn't available, in the perfect kind of health package, we absolutely understood the concern. And so we had a discussion last session, and that was led by Senator Monis Anderson, and we participated along with the Department of Revenue. And again, this session, the agreement was made upon members of, that sort of roundtable, that would be one of the pieces of this bill this session. Another thing that was recently discussed was an amendment that would allow for, so there wouldn't be a dual licensure. And I don't know if any of you had an opportunity to watch all of those discussions, but we're really hopeful that tobacco retail licensure will actually get across the finish line this session. So I want to give an opportunity, because those are kind of the two tobacco conversations, and I want to give an opportunity for any questions before I move into the other parts of the presentation.
Any questions from the board?
All right, fabulous. Thank you so much. I don't want to just talk at you, so please interrupt me if you need to ask a question and want clarity. And there's a lot to talk about, and I'm giving you very high level information. A lot of this gets technical really quickly, so I'm always happy to follow up with some more information. Next on the list is our bill, which is Prescription Drug Monitoring Program sustainability. And ultimately, this is about increasing fees to ensure that the program is sustainable. This is House Bill 2074. It also has an associated policy option package, which is 453. As you can see, there's a zero general fund amount next to that line, and that's because this is a fee increase bill. It requires that prescribers and providers that use the PDMP, actually it's a $10 increase per year. And so fundamentally, we know the importance of the PDMP program, and also just that in previous years, we've had a number of bills that have added additional responsibilities. And so we just want to make sure we have a sustainable program. So if there are no questions, we can go to the next slide. Thank you. We're going to move down to public health modernization. And I know that there are lots of conversations about public health modernization happening and have happened. Representative Greenlick, who was a champion for public health modernization, you all remember how he introduced a number of bills that created the structure and the framework for this program or this initiative. And so local public health authorities and our tribal partners and our new partners, community-based organizations, all are working on how we can appropriately modernize our public health system, how we can focus on health equity and ensure that we achieve our strategic plan goal of eliminating health inequities by 2030, and also just how we can be very responsive when we have not just one, but a number of public health issues that emerge, whether it's harmful algal blooms and cyanotoxins, whether it's a global pandemic such as COVID-19, response to Ebola, or maybe even another detrimental wildfire season and the impact to human health. And so aside from the day-to-day activities of public health, these are all issues that, we have to talk about and address, and modernizing the public health system is a way to ensure that Oregonians around the state have the protections that they need. So first and foremost, we have a policy option package. Our agency request budget, you've probably heard if you've watched some of the committee hearings, that we had a 68.9 million amount in our agency request budget. We were happy to know that the governor prioritized $30 million in the governor's recommended budget. So we support that governor's budget, and so we are talking at the $30 million level. I know that there are a number of partners and organizations that have put forward lots of support, both on the record in written format or vocalized in various committees, that they would like to see the higher amount passed. So that's a discussion that's happening this session. You'll see that there's actually a minor typo in this, but House Bill 2073 was a placeholder that actually wasn't used this session. And so if any of you heard about that placeholder at the beginning of session, that's actually not being used. And we didn't have anything to put in there at any need to address. And so we're really focusing on that policy option package. I know that public health modernization is a huge discussion, as well as all of the great work that you're doing and have done to define health equity, and how we talk about how we implement our state health improvement plan and those goals as well. And so before I move into the rest of the presentation, does anyone have any question around public health modernization?
Well, I can't refrain from making a comment that the $5 million that was initially invested in public health modernization in the legislative session prior to COVID was the best $5 million ever invested of public dollars. And it's great to see the significant increase in investment. Obviously, we appreciate the need and the importance, and this will be well invested as well, similarly well invested. So it's great to see this progress. Any other comments from the board?
Just to quickly, I asked about the American Rescue Plan funds, and Director Allen talked about the importance of public health modernization. So I just, there's a tie there and there's a connection there. So I just love to kind of continue that thread as we move forward in future board meetings.
Angie or Jeff, is there a crosstalk between Rescue Act and public health modernization?
Thank you. I think the one thing to recognize is that the American Rescue funds are one-time only funds, and what we need to modernize our public health system is an ongoing support and a framework. When you think about a large number, like even $30 million, it seems like a huge amount. And then when you look at how we distribute that to our local public health authorities, through all the counties throughout the state, or most of the counties, and also to our tribal partners to do all of their work, and then to community-based organizations, really it's so important that we're able to have that continuing funding amount prioritized and to continue that work. So while there's definitely a connection and a tie, I think it's also really important to make that that point and highlight just how important the vision of public health modernization and the materialization of it and the implementation of it has been, and how much more we have to go. So thank you so much for the comments and the questions, and I'm always available if you have any other questions. So we'll move forward with the home healthcare oversight, and I'm trying to be mindful of time. I know we have a hard stop at 9:25, so I want to give Jeff also some time. So I'm going to go through these as quickly as I can. The home healthcare fee increase bill is House Bill 2072, and ultimately the healthcare regulation and quality improvement unit within the public health division actually regulates in-home care agencies, and part of that work is really making sure that the home healthcare agencies, when they're going out and reaching out to vulnerable Oregonians, that we've got enough information. We've got the licensure, and we're in communication with our regulated community. And so we have asked for this fee increase. It's been quite some time since we've had a fee increase. We want to make sure we have enough to support the program to continue to do that work and to really ensure that the home health services provided to Oregonians, are well supported. Radiation protection services is another fee increase. They do so much work in radiation protection services, House Bill 2075. Ultimately, it gets very technical, so I'll try to make this as high level and brief as possible, but there are a number of changes that would happen in these fees. One would be an X-ray fee increase, which is structured on a tiered system, putting us in line with Washington and California. We have an outdated way of assessing the X-ray fee. Technology has changed significantly. And instead of a big X-ray machine with one tube, we have lots of tubes in a machine and other advancements that create a need for updating our program fees. The other piece is a radiation material licensure fee. We have an X-ray vendor fee. And then the final piece is the tanning bed fee increase. And that's obviously an important part of making sure that all of those fixtures and those machines are safe. So I will keep moving unless I hear of another question, but we've got an EMS modernization bill, House Bill 2076. I think this has had a lot of conversation and attention. This is not a new concept. This came out of a task force recommendation from about a decade ago. I know that Dr. and Senator Bates also had done a lot of work to try to move forward the dial in EMS. And I think that what we've tried to introduce this session is a way to actually put forward a framework to have the conversation to how do we modernize our EMS system and ensure that the right services get to a person in need at the right time. Part of this bill had to do with putting together, restructuring our boards and ensuring that there's an EMS mobilization plan. We also have ambulance fees that have not been increased for 25 years. And so that's a part of the bill. Due to a lot of feedback we received and people that really wanted, our partners that really wanted more time, we've amended the bill to actually direct OHA to pull together an interim work group to work with all of our partners to come up with legislation for 2023 that would mirror what we tried to do this session. And in addition to that, we would have our ambulance fees as well. So that has passed through. It has a work session, and then it will, we expect it to pass into a joint ways and means. We have a lead-based paint fee remediation bill, or not fee, but a lead-based paint remediation bill. This is House Bill 2077. Very briefly, I'll just say that we have, on behalf of the Environmental Protection Agency, we have implemented the lead-based paint program since 1998. In addition, since 2010, we've been a part of the lead-based paint and repair work with our partners at the Construction Contractors Board. And while we really appreciate being able to do this work, we don't have an opportunity to actually compel the cleanup of lead-based paint when they've been handled or mishandled by our regulated community. So while Construction Contractors Board can, work with their regulated community, which is contractors, we have schools, childcare centers, and actual property owners that that's our regulated community. And so what this bill does is it just allows us to compel the cleanup of the mess. We can currently cite for being out of compliance, but that lead-based paint mess and those hazards can be left over without any kind of cleanup required. So this bill is really important. It's passed out of the House Healthcare Committee and is over on the Senate side. And so it passed off the House floor. So we expect there to be a lot of excitement about moving this bill forward. And hopefully it will also pass out of our Senate Healthcare Committee. We have a housekeeping bill for public health, Senate Bill 64. This bill passed out of the Senate side and will be coming over to the House side soon. And ultimately, our housekeeping bills have a number of components. I'm always happy to provide you with details if needed, but I'm going to hop over a little bit further and get to the rest of the presentation.
We have cosmetology fees, which are part of a policy option package for our health licensing office, as well as respiratory therapist fees. These two parts of the health licensing office are incredibly important because the way that our health licensing office is structured, we have staff that are divided up between all of the boards, and we've had such so much increase in cosmetology and also respiratory therapists. The work has increased, and so we want to make sure that we're able to provide the appropriate support and technical assistance to all of those that are licensed by health licensing office. In addition to that, we have an Oregon Environmental Laboratory fee. I think most of you know that we actually accredit certain lab functions, cannabis, environmental labs, drinking water. We get a small amount of federal funds to regulate the drinking water aspect or for those lab accreditations, but over time, we've just needed to stabilize that work and continue to have a robust accreditation program. So those fees there's a part of an increase there. And, I can get into the technicalities of that if you have any questions. But for now, I think I think we are at all of the public health pieces. Maybe we'll move to the next slide and see if I've missed anything.
There's some more on here, Angie, but is this the next slide?
Yeah, thank you.
Here we
Perfect. Go. Okay. So I think that I'm going to turn it back over to my colleague, Jeff, but I wanted to give one last opportunity if there are any questions for the public health pieces that I presented. All right, well, I want to thank you all, and I'm always available if you have additional questions, and over to you, Jeff.
Thank you, Angie.
Thanks, Angie. So a lot of these are updates from our previous conversation last month, and I'll try and run through them. House Bill 2164 is a Cover All Kids expansion, kind of a Cover All People pilot, building on Cover All Kids. There's been some evolution around this bill. Representative Campos has a bill, 3352, House Bill 3352, which does something similar in a much broader way. So it would expand coverage to those who are ineligible but for immigration status and under a certain poverty level to the entire population. Those would be the two, kind of main limiting factors: the federal poverty level of the population and ineligible because of immigration status. So there's kind of another bill with a similar target, but a much larger potential budget request moving through the process at the same time as this bill, House Bill 2164. And this is the legislature's prerogative and the legislature's decision. They are the ones that make funding decisions. So the governor had recommended $10 million in her governor's recommended budget for this pilot. And I think right now, my sense is that the legislature is looking at more dollars, frankly, for more coverage. And so I think we'll kind of see that play out in House Healthcare, where both of these bills are right now, and get a sense of which bill is likely to move forward and at what cost, which will help us understand to what degree the population in question will be covered, and we'll have an expansion of coverage.
Jeff, is there an estimate of what proportion of need that pilot would serve?
I'm not sure I get your question, Dr. Santa, or Dr. Bangsberg.
It's a pilot program, so I'm sure I'm making an assumption it's not serving everybody who doesn't have documentation status. And is there an estimate of what proportion of need it would cover?
There are a couple estimates. Depends on. Thanks for the question. I think I understand now. And I think the key in my response is we've been working really intensely with community to direct how that limited amount of dollars that are identified in the GRB would be used for this population. So to your question, where is the need and where would the dollars go in the pilot? I think that community conversation right now is centered around, a potential expansion for kids who have aged out of Cover All Kids and parents or those who have dependents who are Cover All Kids. So kind of two different populations within that population. Again, this is really kind of co-created or community driven, and we'll kind of keep being that way as long as we have limitations on the dollars, and we're kind of figuring out how best to expand eligibility in an incremental way.
Thanks.
The next bullet we have on here is a real D and SOGI, race, ethnicity, language, disability, and sexual orientation and gender identification data collection. This has been something that the board has actually prioritized for several years, and the agency continues to work through. So this is a timely bill, and has a couple different key components in it, working on the data systems and infrastructure that support this work and working to better collect this data. I think that we'll have to see how this bill kind of keeps going through the process. I know that the negotiations and amendments are pretty intense right now. The next bill is around regional health equity coalitions. Regional health equity coalitions serve as local experts in the field with expertise and experience regarding health equity. And this bill would expand the regional health equity coalition model to cover more places in Oregon and institutionalize the definition and program of regional health equity coalitions in statute. This bill had its public hearing early on in Senate Health and was worked with an amendment that made minor technical changes and is awaiting assignment in Ways and Means. There is a governor's recommended budget component that goes with this to fund these regional health equity coalitions. Our next bullet is around healthcare interpreters. The agency had a bill, House Bill 2087, which is no longer moving forward. The bill did two things really. Mandated that there has to be reimbursement for fee-for-service OHP providers who provide, who follow the federal guidance and provide healthcare interpretation, and it revises a legislative finding about the use of healthcare interpreters. That's all to say that bill is not moving forward. Instead, House Bill 2359 is moving forward. House Bill 2359 is led by Representative Salinas in her office, and is much broader than the bill that I just discussed, and is really focused on, in addition to continuing to build on Oregon's progress to use, train, and mandate healthcare interpreters, qualified and certified healthcare interpreters, really contemplates accountability for the use of healthcare interpreters at a language service company and provider level. Our next bullet here is health equity innovation and implementation. This is a policy option package before the legislature to kind of right size the division of equity and inclusion. Given our priority around health equity, our strategic goal, there's an investment that would need to be made in order to ensure that the Office of Equity and Inclusion has the infrastructure it needs to support us meeting that goal. The next bullet on this slide here is the enforcement of the healthcare cost growth target, House Bill 2081. House Bill 2081 was heard early in House Health and worked in House Health and moved to the floor because it does not have a fiscal impact, moved to the floor of the House for consideration. And after it moves to the House, it'll move over to the Senate side. It hasn't been heard in the House yet. It's been carried over since the 24th. And just, to be clear, this is the accountability and enforcement pieces of the cost growth target. The state had the authority to implement the program and did all that work with the implementation committee. And I think the board is hearing an update on this very soon. So I'll stop there. The next bullet is around value-based payment and kind of continuing to align and create greater utilization of value-based payment. This bill, House Bill 2082, is not moving forward. As part of the healthcare cost growth target work, the recommendations provided by the implementation committee, there are principles around value-based payment and a voluntary compact. I think I'm going to put Jeremy Vandehey on the spot for just a second and see if he wants to make any comments about that value-based payment compact or provide any kind of update.
Sure, thanks, Jeff. And I think we've reported on this before, but this last week we announced that we have 40, actually I think we've had 2 more, so we're going to have 42 organizations signed on to the value-based payment compact, including all of the major insurers in the state, hospital association, medical association, most of the large health systems, several large clinics, overall representing about 72% of the covered lives in the state. So have made a ton of progress on that compact and excited to see the work get underway.
Thanks, Jeremy. and then I'll pause after my last bullet for any questions. There are some more slides with some more bills. The last bullet on here is to reduce pharmacy costs. The agency had filed House Bill 2080. House Bill 2080 is not moving forward. The House Health Committee is just jam-packed. But Senator Patterson took up the bill on her own and filed it as a priority piece of legislation, and Representative Nost and Representative Prusak signed on. So Senate Bill 848, when it was filed, was an exact replica of the -2 amendment to House Bill 2080, the agency's pharmacy omnibus bill. We've since filed another amendment to this bill after working with the Oregon Medical Association and CCOs. Really, the pharmacy bill does two main things. One is establish this Office of Pharmacy Purchasing to better leverage the state's purchasing power and to drive down the cost of drugs. And the second is kind of to resolve a continuing concern or issue around preferred drug lists for CCOs. Before I move on to the next slide, are there any questions about any of these bills? I see Dr. Santa.
Yeah, Jeff, just a word. What are the controversies around the RealD, the data collection bill?
Well, I'm glad that you asked plurally what are the controversies around it rather than what's the controversy around it. I think there's a couple that I don't want to say that we're not plugging away at this. I think where we're working really hard right now is to find the right balance between collecting the data, having the right infrastructure, and working with providers who have to collect the data so that they're able to do that. So it's really that last piece I mentioned, Dr. Santa. It's around how do we actually do this in a way that meshes and fits with the system as it exists as best as possible, as most efficiently as possible, I guess I would say. And we can follow up with more information on this particular bill. I'll make a note.
Jeff, we should probably finish up soon.
Okay, I'm going to keep going. Next slide. So I got 2 minutes now. Thanks, Dr. Bangsberg, for the reminder. I'm going to flow through these pretty fast. I want to look at these and just see if there's anyone that I actually want to use our time on here. And I think there is one that I'd use our time to talk about, and that's the third bullet on this list. The review of healthcare mergers and acquisitions. The agency originally filed a bill, House Bill 2879, which has not moved forward. House Bill 2362 is similar to the original bill that the agency filed and is sponsored by Representative Salinas and some other legislators, and really does carry forward the original idea that the agency proposed. And the board has a piece of this bill potentially, so I should flag that for you all. Specifically, the board is called out within the legislation to help inform or direct the development of criteria for when some of these changes and transactions that would go on amongst healthcare entities, and to have the board kind of inform what that criteria might look like for a deeper review process. So we'll have to keep y'all in the loop about this bill, given it explicitly calls out the board and has a role for the board in relation to developing criteria for review of health entity material change transactions. That's 9:25 on the nose, Dr. Bangsberg.
Thank you, Jeff. We could take a comment or a question or two before moving on, if there's any from the board.
I see Kirsten.
Kirsten, yeah, I need to go to gallery view. So Kirsten, do you have a comment?
Yeah, I mean, I'm really excited about many of these pieces of legislation, and I think they reflect the priorities of the board, whether that's RealD and SOGI or the cost growth enforcement or mergers and acquisitions for health equity, so many. And I was wondering if there is a role for our board to play in helping some of these get across the finish line. Is there something helpful we can do?
Yes. Next question. I think it kind of depends on the bill in particular, but I'm being a little bit facetious, but the answer is yes. Some of the bills are not sponsored directly by the agency anymore. That doesn't mean the board couldn't take a position. I did look through the board's packet and saw that decision-making document that you all have developed for when you choose to make a decision. I think if that's a direction you want to go on any of the bills, we'd like to make sure that the subject matter experts in GR team inform any decision and provide maybe some more analysis and background so you're able to kind of make a decision. I know that it's happened before. I think that the bill that comes to mind for me for the board was around vaccines. I think actually the board issued a letter supporting some of the legislation in past sessions regarding vaccines. So the quick answer is yes, it's possible for the board to kind of get involved and support some of the legislation. The last thing I'll mention is we'd want to stay kind of close to the governor's office and ensure that we're aligned with any direction the governors have. But to your point, Kirsten, a lot of this legislation, even when it's not directly ours, is aligned with the agency and governor's priorities.
Yeah, I just would add, I think obviously the legislative process is its own process, moving at its own speed, not that does not align exactly with monthly board meetings. And there's obviously lots of sausage making that happens in the process. I think that unless it's a bill that the board has previously really had some time to take a look at or as part of the governor's agenda, I think a safe spot, I think, is more kind of supporting direction of a policy, because obviously things change on a dime as amendments are flying, and a bill that you love today might be a bill that you hate tomorrow based off of a change. So I think just would keep that in mind. It's probably better to stay at sort of the broad policy direction.
I think as someone who helps track the agenda with OHA, we have a really full docket with cost waiver, health equity, our Medicaid waiver, cost growth target, and health equity. And if there's an important issue, we should take it on, but then I think we'll require a fair amount of deliberation, discussion in terms of understanding all the issues related to it. So I think if something comes up, we should discuss it, but recognizing it's going to take some time away from these other important and full agenda we have this year.
And I'm thinking more specifically, like, especially because of those full agendas, if there's our tools in legislative packages that we want to move based on that work that we're looking at doing and our priorities, that staff be, I think we rely on OHA staff to kind of highlight it for us and say, like, but anyway, to say that please bring it forward if there's that space, because we do want to have the tools and do want to emphasize our priorities.
Great, thanks, Kirsten. John?
Yeah, just to comment on the merger and acquisition thing, as I read the bill, I was very proud that the OHA definition of equity is in the bill, and it seems is an important part of the bill. On the other hand, I was surprised, and I'm not as knowledgeable around language of bills, to find that it looked like the policy board was playing a major, was going to be a venue for that bill, which my recollection in our discussion was OHA brought the bill or brought the issue to us for advice, and not to place the actual discussion of those mergers and acquisitions at the board. So I agree that I don't think we're in a position to act swiftly, but I hope if the bill survives the equity definition and the importance of equity in evaluating mergers and acquisitions remains, the degree to which OHPB remains in the bill, I would leave to others, because I don't think we really discussed that.
Yeah, and I'll just share in the most recent amendment posted to the Oregon Legislative Information System, the board is down to, I think, that one key role I mentioned of like kind of helping the agency develop criteria for when they review stuff, which I think is in the sweet spot you were talking about, Dr. Santa, of the board kind of providing oversight and aligning with health equity goals without directly maybe being a venue for each conversation.
Thank you, Jeff. Thank you, Angie, for that summary of the legislative actions. Discussions taking place. Next on our agenda, we have Jeremy Vandehey and Sarah Bartleman, who will talk about a framework for monitoring the cost growth target program.
Great, thank you. I'll dive right in, and I'm just going to tee it up and then turn it over to Sarah. So just a reminder that we're bringing this back to you. We've talked about this a couple of times, but really bring it back to you for some more thorough discussion around one major priority area within the cost growth target program. As we've talked about, there's several different buckets of work within this, but one of these is the framework for how we're monitoring to make sure that negative things don't happen as a result of pushing down on cost, and also making sure that we really keep equity front and center. So we're bringing this back to you today for some more discussion. This is really a good opportunity for the board to provide some input and direction. There's going to be some cross committee work that happens as a result of this, as well as some cross agency coordination. I want to go to the next slide. There were 3 recommendations coming out of the implementation committee as it relates to quality and equity. And the reason this came about is the legislation had specifically called out that that quality be measured as part of the overall cost growth target program. It was pretty silent beyond that. I know that back when the original task force that recommended this program several years ago had made its final recommendations, they just wanted to make sure that, and Kirsten, correct me if I'm wrong here, I mean, they really just wanted to make sure that there was sort of a holistic view of what was happening with performance, that is part of that cost equation, that there was some view of, well, is there a trade-off for quality there? The governor, when she appointed the implementation committee, asked specifically that the committee really look at equity and make sure that we protect against creating new inequities or unintended consequences. So we had a whole work stream related to quality and equity, and there were really 3 recommendations that came out of that. One, setting a core set of quality measures that would help give us a read on comparing quality as we're looking at cost. Creating a mechanism for monitoring for unintended consequences and making sure that we weren't exacerbating existing inequities, but then more proactively thinking about what data we could collect and information we could collect that would help us actually have a better understanding of where there's opportunities to improve equity. So there's sort of a difference between just protecting against negative things happen versus having a better understanding of who's really struggling with costs, and getting better data around that, so we could have more policy conversations down the road around how do we correct that. We've created captured all this in sort of a framework for monitoring. This is going to require coordination across the Health Plan Quality Metrics Committee, the Health Equity Committee, and the board, as well as coordination across OHA and DCPS, and Sarah will talk a little bit more about how we're planning to divvy that up. But we sort of bucket all this into a framework to provide some structure for this conversation. And really the key, one of the first places this conversation will start is with the Health Plan Quality Metrics Committee. And at their last discussion, they've really framed this as sort of first and foremost, let's make sure that we do no harm in the process, and thinking about what metrics we could be taking a look at to kind of make sure that we're not doing harm in the process of containing costs. Next slide. Oh, why don't we go back one more? Sorry. Just a reminder, and it kind of helps set the stage for the discussion. We see the board's role here, and you all agree that this is really a collaborator role. It's an opportunity to provide some direction and guidance, help us really shape how this framework for monitoring is developed, provide some guidance that will help with the committees that are going to be diving into some of this work. We're not asking the board to come up with something totally new. This is really a spot where the implementation committee has broadly said what they feel like is important to do, but we really want to make sure we get some guidance from you all as the Health Plan Quality Metrics Committee and Health Equity Committee start to roll up their sleeves and think about how we would specifically be measuring things in this space. So with that, let me pass it on to Sarah.
Thanks. Okay, next slide. So I want to revisit the terminology. You might have raised your eyebrows when you saw the second slide with those 3 strategies and saw the unintended consequences language come back up. I know that when we initially presented the implementation committee recommendations to you and to some other stakeholders, there were concerns about that unintended consequences framing, that was too narrow. It really wasn't reflective of the potential impacts on equity. We've gone back internally, we've considered what the implementation committee's intent originally was, and we are now using the phrase negative impacts of the cost growth target to describe that second strategy. And that includes negative impacts in a whole bunch of directions or domains, and I'll talk more about that later. So I just wanted to reflect that we heard you, I think last month when we talked about this, and we heard the stakeholder feedback, and we have revised that language. So strategy 2 is negative impacts. Next slide, please. So the purpose of the draft framework for monitoring, which you have a copy of the current draft in your materials packet, we definitely see this as a living document. This is a way to provide structure and documentation as we work on operationalizing these 3 strategies. So as Jeremy mentioned, there is cross-committee work, there's cross-agency work, there's a lot of feedback, and we see this framework as a place to hold all of that information as it comes together. So as the committees move forward and give direction, as you give a direction, we'll add in those details. So that could be, hey, here's another negative impact that we weren't thinking about that we should build out. Here are those core measures and the data sources that are recommended. Here's what we recommend for reporting, all of that. So this framework document will be updated throughout the course of the year to reflect those conversations. So it's always pulled together in one piece. We also thought that it would be really important to clarify who owns what part of this. So while the implementation committee did recommend these 3 strategies, and we're talking about them as 3 siloed strategies, they overlap. Incredibly complex conversation in terms of separating out what goes where. And so we can talk about measuring a standard set of quality measures, but of course there could be some negative impacts to quality. And so how do you separate strategy 1 and strategy 2? We recognize that that is an ongoing tension, and that's one reason to keep bringing it all together into this broader framework, but that we need to piece out the work to operationalize it and move it forward. So we're dividing things up and asking different committees and different partners to help us with different pieces of it, and then it will all come back together into the framework. And then finally, this framework is not intended to reflect all of the measurement and analysis we'll be doing for the cost growth target program. The framework for monitoring is specific to the quality and equity work stream of the cost growth target program. We also have the data use strategy, or the data work stream, and that's where we'll do all of the analysis of cost growth, key cost drivers, and related analysis about price or other more granular cost pieces. That could be things like, I'm not even going to talk about that. We're really focused here on quality and the other components that might be affected because of the cost growth target. So not to say that it's not important to measure all of those other things. We are, it's just external to the framework. And again, this is one of those places where the work completely overlaps. It's all related, but we're siloing it out for the purpose of building a program and moving it forward. Next slide. So the way the framework document is laid out, we have one section for each of the 3 strategies. I'm going to walk through each of them briefly today and just give a quick summary of what's in that strategy and what the current status is and what the next steps for development are. And I think the feedback that we're looking for from the board today is really at a high level. So are there major content areas that are missing within these strategies? Do you have thoughts or feedback about the proposed process and interactions between the committees of the board, between the board and the committees, between the board and the staff and the committees? And then what level of detail will be helpful for reporting back? I think we're happy to continue to share the draft framework document as it evolves and as we add to it, but we don't necessarily want to get everyone down in the weeds of every single data source or every single measure. So as I walk through this, think about what kind of information might be helpful to hear as we move this work forward throughout the year. Okay, one more slide, please. All right, so strategy 1, public reporting on a standard set of quality measures. So the purpose of this strategy is to help inform interpretation of performance relative to the cost growth target. So are we seeing any detrimental effects or positive impacts? It could be positive, related to quality as payers and providers take steps for cost containment or to meet the cost growth target. We think that this context will really inform the content for the public hearings, really provide context for public reporting. It's really aligned with Oregon's commitment to quality measurement and transparency, and it builds on our existing foundation for quality measurement, particularly with CCOs, but also with the public payers. Our intent for this strategy is to develop a public report on the selected quality measures using data from the all payer claims database. So the intent here is not that we create a whole new infrastructure or require payers and providers to start submitting a bunch of new data to report these measures. This would be an OHA produced report, and that we would be reporting measures statewide and then across market, Medicaid, Medicare, and commercial. So we've done a lot of work in the Medicaid quality space. We've done a little bit in the commercial space with PEB and OEB. Medicare does its own quality reporting at the federal level, but this is really an opportunity to standardize and bring that consistent look for this core set of quality measures across the whole market and understand what that landscape looks like. We might also get into payer and provider reporting in the future, and we do intend to stratify all measures by a number of variables where possible. So the intent here is that we would also be able to look for disparities, potential negative impacts of quality within these measures as well. The implementation committee recommended that since the Oregon Health Plan Quality Metrics Committee already has a aligned measure set, a menu, and a process for selecting measures and expertise, that it would make the most sense for them to help recommend which measures we should actually use. Excuse me, next slide, please. So we introduced this request to the Health Plan Quality Metrics Committee in February, and we continued the conversation at their March meeting. We have proposed a process and set some parameters for which measures they should, which measures in their current measure sets are most appropriate for this use case. And I think that use case conversation has been really interesting with Health Plan Quality Metrics Committee, because this is not intended for incentive measures. This is not intended for contracting. This is for that high level statewide public reporting purpose, for that context and transparency lens. And that's a little bit of a mental shift from the work that HPQMC is used to doing. So we've proposed the process and some parameters. They have accepted this challenge and are going to continue to work with us to help recommend a subset of their measures by June. Over the last couple of months, there have also been some ideas suggested that there are other things related to quality that might not be captured in the HPQMC menu set, and that we want to explore some existing reporting and data sources that we could tap into. That might be some of the existing federal Medicare reporting. There's some existing hospital quality reporting. There's a lot of stuff already out there, and we want to see if we can leverage some of it to provide some more context. We didn't want to just open the door really wide and say, let's figure out how to measure everything from scratch, but we recognize that not everything that we might be interested in is on the HPQMC menu, and we might need to fill some gaps. Let me pause there. Any immediate reactions or questions on strategy 1 quality measures?
Thanks, Sarah, for this, and I really appreciate the reframe on the negative impact as well. I want to give voice to the reality of COVID vaccinations in the context of this conversation. We're thinking a bit about how the 2021 measure sets are meeting with a lot of reaction, I think, in communities about the capabilities in the systems itself, in the delivery system itself. I mentioned this in a couple other contexts, and I bring it up here relative to this conversation, because as I look in the detailed document around using 2021, even though it's a report only, I'm curious about how we're going to navigate the conversation, both recognizing the impacts to the delivery system on COVID vaccination and the efforts there, along with trying to, engage in and continue to populate the really highly important work around health plan quality measures. So
thank you.
how are we communicating and navigating that?
Well, let me clarify something because I think this might be just a mistranslation. So we asked HPQMC to use their 2021 aligned measures menu set to select from, because that's what they currently have. HPQMC is also going through a process this year to update the measure set, but we wanted this request and this body of work to start moving forward. We didn't want to wait until there was a 2022 measure set. That does not mean that we're going to start measuring and using 2021 as a baseline of measurement for the quality measure. We have not even had a conversation about which years we start measuring, if we look back, if we look forward. So sort of disconnecting the year of the measure set versus the year that we would actually look at the data. We haven't gotten that detailed yet. Does that help?
Yeah, thank you, Sarah, it does.
Ebony, do you have a question?
Yeah, my question, and hopefully it's not either getting too far into the weeds, and I'm hoping that it's not irrelevant. But what I think about is just also when it does come to quality measures, data tracking, and when there's major kind of shifts in kind of what systems begin to track, that means that your infrastructure, has to be also ready and prepared, as well as then your contractors, your providers. And so I guess my one question is, are these data that are collected in MOTS? And the reason why I bring that up is because I know that, there's kind of this whole overhaul process that's underway, or hopefully will resume. But then the other question I also have is that I also know, in light of the pandemic specific to COVID-19, a lot of reporting requirements and just reporting processes have kind of been put on pause. And so how do you think about kind of the cadence of then, getting a system up and ready and running again, specific to kind of, the efforts around data tracking? And maybe that's too far into the weeds. So that's just
no, thank you. I mean, those are both great questions. Let me try to answer. So the intent here is that this is a report and a reporting system that OHA will be working on. So we will use data that we already are collecting on an ongoing basis through our all payer claims database. We are not planning on, at this point, requiring new data submission or data collection from payers or providers. We're not standing up new data collection mechanisms to support this use case of quality reporting. That means that we are limited in which measures we can produce. We are limited to claims-based measures, and there are some pros and cons to that. But we want to recognize this is not about creating additional burden for the provider system. This is about using tools that we have, fully utilizing our APAC data so that we can have better insight into quality at a high level across the state. So at this point, we're not looking at any measures that would be produced using MOTS data. That doesn't mean that that might not come up in the future, but currently that's not on the table. And then we are not planning on anything that requires new provider reporting, new provider infrastructure. Obviously, if we select measures and we say these measures are what we will be publicly reporting on for the cost growth target program, whether or not they're incentivized, whether or not there's any other mechanisms there, even if that's not our intent for the cost growth target program, we all know that once you start measuring something and reporting on it, people pay attention to it. And so that doesn't mean that if we pick this, a payer might come to a provider and say, we're going to start focusing on this, and maybe now we have a contractual requirement. We're not trying to push that through this. This is about reporting, transparency, monitoring, but I want to be honest that could definitely happen downstream, even if we're not setting it up that way as the intent. But I think we're hoping to avoid that provider burden. And again, recognizing pandemic, we're thinking this year is planning. This year is figuring out what to measure, what data sources, what a report looks like. We might not start collecting the data or rolling out a report until next year at the earliest. We haven't talked about the timing yet. So I think, again, knowing that we're not intending to ask payers and providers for any of this quality data will hopefully help.
Kristen, you had a comment?
Yeah, I don't know, and I'm hoping this isn't the antithesis of that, but I guess thinking about the slide where you talked about what's in the report of kind of measurements, quality measurements at the state level and by kind of payer type. And then maybe future reports would contain provider, or I'm going to say carrier rather than payer again in that case, information. And and that sounds great and reasonable, and let's get this report stood up and going first. But I did wonder if, like, although it wouldn't be in the report, would OHA still be observing kind of what the baseline or trends for carriers and providers, even though it wouldn't be in that report?
So sort of, I think it's easier to look at the carrier level first, or the insurer level first, because if you look at the HPQMC measures, they are designed for health plan level measurement. And so there's sort of a direct translation. We can look at all of the Medicaid market across the state, all of the commercial market across the state, and then we can start looking at carriers, and that's pretty straightforward. I think we want to make sure that we have confidence in the data, the measure production, that we have a good validation process set up so that carriers could review the data before publication. But it seems like that step is more within reach. I think provider level measurement is a whole different conversation, and I don't think we're making any commitments at this point because there's additional complexities. Not all health plan quality measured menu measures are appropriate for provider level reporting. And we want to make sure that we take that into consideration. There's also a lot of really wonky details about, oh, your denominator, who's actually in it. And if you're talking about everyone who's enrolled in Medicaid or everyone who's enrolled in this commercial insurance plan, that's a lot more straightforward than everyone who sees this provider, like sees them win. So there's just a lot more nuance to work through. And I think we're a ways out from provider reporting. And we'll want to make sure that we have a good process and opportunity for buy-in and thinking through all those details before we get into that. But the carrier level should be more straightforward, but again, making sure we have good validation and communication before we roll that out. Okay, should I move on to strategy 2? Okay, so strategy 2, negative impact of the cost growth targets. I think, as we've talked about before, because payers and provider organizations could potentially take actions that impede access to needed care or have other adverse effects, we want to make sure that we are monitoring for those effects. The implementation committee had recommended that we work together collectively with the policy board, the health equity committee, and the health plan quality metrics committee to develop a plan and identify measures for monitoring these negative impacts. So this is, in some ways, a lot more vague and open-ended. There are a lot of different directions monitoring negative impact could go. We've started identifying some of those topics, domains, buckets, whatever we want to call them, and those are in the full draft document. So for example, we've talked before about negative impacts on the healthcare workforce. So our wages, salary, hours worked, benefits, anything like that being modified in a cost containment effort. We've talked about the impact on consumer out-of-pocket spending. So our premiums going up, our deductibles going up, our the percent of dollars spent on healthcare as a percentage of total income or total household spending, how is that changing? Again, thinking about that overlap between strategy 1 and 2, there might be some populations or some specific areas of quality that we want to drill into a little bit more closely. That could be regional, that could be population-based, could be access-based. Is it harder to get appointments with specialists if those are expensive specialists? So this is a kind of open-ended conversation at this point where we're trying to get broad feedback on what are those things that we should be worried about. And one, I cannot remember which conversation it was, but there was some framing that came up that was really helpful, that this is really a retrospective look. That we want to think about what could happen, and then we want to measure to see what did happen. So we can't necessarily predict everything, but we want to have some things that we are possibly concerned about and be able to monitor that in the dashboard to know if there's any of those sort of early warning indicators that things are going sideways. We're not going to get everything right off the top. There'll definitely be some things we didn't think about, some things that come up, and we'll want to incorporate that. So again, this is a living document, a living approach to this monitoring, but we do want to set some of those parameters, or not parameters, those buckets or those areas of concern up front and make sure that we have the infrastructure and the plan at the state to collect the data and report. And again, I think we're really focusing on using existing data. So for example, for those, the wages for the healthcare workforce and the benefits and the hours worked, we're working with our colleagues at the Oregon Employment Department to see if they have some data that we can tap into. We're really not trying to stand up a new massive data collection effort specifically for this monitoring. We might find some gaps where we need to revisit that, but at this point, we're really trying to utilize existing data.
So,
Next slide.
Oh,
In
Sarah.
terms of the current status of strategy 2, we've revised the terminology as we've talked about. We're exploring potential measures for workforce, and we are having an initial conversation with the Health Equity Committee later this week. So we have not yet started the conversation with them, and we want to make sure that they're really thinking about it, not from a measure selection. It's not as clear cut as strategy 1, where we say, here's a menu, just pick a subset. It's much more, what are the areas that we should be concerned about? What are the things that you would be worried about? What are the different perspectives we should be bringing to this conversation? So we're really hoping for the Health Equity Committee to give us some guidance at that level, and then we'll do some of the legwork to figure out what are the different ways we could measure or report on those things.
Hey, Sarah, can I just jump in here real quick? So really specific, I think a little more specifically for what we're really hoping to glean from the Health Equity Committee is really from an on the ground perspective. If things are going negatively, what would that look like to members? And then be able to take that input and take it back to the Health Plan Quality Metrics Committee and say, okay, what's a metric that maybe helps us monitor that? But we kind of want to get the people version, what would this actually feel like to patients and to providers, and not get boxed in on the metrics at the outset.
Jeremy, I'm really glad to hear you say that, and thank you, Sarah, because I was thinking, if we're using existing data and these are negative impacts are truly unintended, there probably may not be a data element that picks up unintended negative impacts. And is there a voice for consumers or providers to bring something forward that then could be addressed in short order?
Brenda?
Yeah, thanks for that, Sarah. I do know that there are some that we may not have available data for that we already know are going to be kind of those early watch indicators. And of course, strong access to care measures are, first and foremost, I think, on my list. And I'm wondering about your thinking, or the OHA's thinking about how to use existing data whenever possible, but simultaneously build for what you already know that we're going to need. In COVID, we saw a lot of that early on around how the state could really harness reporting capabilities. I'm thinking about just managing hospital beds. So if we have certain avenues that we've kind of walked through within the delivery system itself to be able to monitor access, or through patient-centered primary care homes and those sorts of things, that we do both. And I get the bandwidth issues, and I just don't think that we're ever going to get outside of wondering about access. So thanks.
Thank you for that. I think that is the intent, that we would use what we have and figure out creative ways to use things that we might not be looking at that way. I think hospital beds and some of the monitoring that's been set up for COVID is a great example that we should look at a little bit more closely. So yes, I think that's the intent. I think we don't have the bounds on this conversation yet. I think we want your input. We want the Health Equity Committee's input on where are the areas we should be focusing our attention. And then we'll start looking at what the data sources are and where we might have gaps or what we can creatively repurpose.
John, do you have a question?
Yeah, I've been thinking about this, and I think, Sarah, one a challenge will be figuring out who didn't get something. And whether your database can, for example, identify that, well, there was a population of African Americans who the database shows claims for them, but when it came to screening them for cancer of the colon, that didn't happen. When it comes to preventive sorts of things, the first 70% is usually the easiest. It's the 30% that are difficult. And figuring out who that 30% is important, because that's usually where the equity issue is. Metrics and scoring, for example, decided to no longer incentivize screening for cancer of the colon. They did so because it was increasing on an annual basis. We were up to about where the rest of the country was, and it was felt that this was a standard of care and there were better targets. However, that's a screening that we now know is not occurring in African Americans and not occurring in people of color. And you know, so really some of those, it looks like we're doing just fine. We're at 70, 75%. It's who isn't getting it. And I don't know if you'll be able to figure that out, but I'd keep that in mind.
Thanks, John. I think similar to strategy 1, whatever we land on here for the right areas to focus on, whatever the right measures, data sources are, we do want to stratify by as many variables as possible. And that is going to be dependent on a lot of things. It'll be dependent on what we're looking at and the data source and who collects it and the quality of the data. So we can't promise that we'll be able to look at everything in every way that we want to, but we can commit to reporting and breaking down the data to help identify where there might be some gaps or those populations that are missing services or that have other access barriers. I think it's a little bit hard to talk about this now because we don't have concrete examples of what could be in this bucket. But I think just like for strategy 1 and the quality measures, we do want to stratify everything and look to see who's receiving or not receiving services or where the impacts may or may not be being felt.
You know, I just would add, it's not like the world works perfectly today. I mean, there's those gaps now, and so obviously there's a concern it gets worse. But I think there's an opportunity to kind of take a step back and say, throughout this conversation, how do we want the system to be performing, and whether that's measuring against the cost growth target, whether that's measuring for unintended consequences as we move to value-based payment or move to global budgets. It's just, I think there's an opportunity to say, what's the type of, if the system's working efficiently and it's getting folks what they need, you know, we should be seeing high quality, high value care go up, and we should be seeing low value care go down. And I think there's an opportunity to just kind of keep that lens and really think about a framework that's more broadly thinking about what's a high performing system look like.
Sarah, we have about 12 more minutes. Do you want to go on to strategy 3?
Yes. Can we go forward 2 slides, please? So strategy 3 is a little different, and this is that prospective retrospective switch between the strategies. So we know that once we've done all of this measurement, whether that's strategy 1, strategy 2, the data use strategy, we've looked at variations in utilization, spending, cost growth, we've looked at cost growth drivers, we've looked at variations in quality, we've looked at variations in access or any of the other negative impacts that we've decided to focus on. We can review those results and talk about them, and we can think about what are the potential barriers or the problems in the system that led to any of those variations or disparities that we see. Then identifying those barriers that contribute to the higher healthcare costs for certain populations can be identified, and we can talk about what the strategies are or the policies that could help address those barriers. So this conversation is a little bit down the road, or maybe down the road's the wrong framing, but something that we'll be doing as we go. It's not that we're going to say, here's our list of 5 strategies right now that we think these are the things we need to do. That might come from other initiatives, from other conversations, but we really see this as we continue to build out the quality measures and the negative impact analysis and reporting, as we pull all of this information together, this is a placeholder for that conversation, and understanding that there are additional barriers and that measuring quality and access and cost growth drivers is not the only thing that we can do. We need to take a look at these other pieces, and we need to think about what some of those strategies or policies are that we might want to advance. So this is, I think someone described this as making sure we didn't miss anything. This is an opportunity to come back and think about things more holistically and think about other opportunities for policy or for action. So this is more of a reactionary approach. So once we see how things are looking, once we see what's happening, once we've looked at those early warning indicators or dashboards, then we can come back and have a conversation about why and have a conversation about what we might want to do about it. So this strategy we think is a little bit more developmental. Next slide, please. In that it's pending development of the other strategies. We will have some discussion with the Health Equity Committee about this and make sure that we're not missing anything from their perspective and that this works from that consumer perspective as well. But we think we'll keep coming back to this as more of a framework for the conversation or a way to have the conversation rather than we will have a set of things that we're measuring for strategy 3. Does that make sense? Should I explain more? Brenda, please.
I appreciate it and I understand why you've got it staged the way that you have. One of the concerns I would offer for consideration is that we actually don't punt this for downstream, but we actually think about like, what is the quarterly review process for this specific strategy that we put in front of us, even though it's a developmental thing, we're harnessing the knowing and the awareness that these are real issues that are currently happening today, that they're not I see the dependencies that you've got created for strategy 1 and 2 and why 3 comes in sort of in a second stage. Again, I would just encourage us to think about them simultaneously so that we're just holding this. This is like such a big deal in the space of health equity that we want to make sure that we're carrying it, leading with it, not trailing with it in a bit. So however we sort of create that kind of framework so that we're constantly cultivating that conversation. I just don't want to miss it. It's a big one. Yeah.
Thanks for that.
Other comments?
Just wanted to say a general comment. I really want to thank Sarah and the team for their process and approach to this framework. I've really enjoyed seeing the evolution of this, really supportive of the language around strategy 2, going from unintended consequences to negative impacts. And I really appreciate the intentional outreach to some of our committees and the connection to what's already existing within OHA, and to not just sort of like create new things, but being very thoughtful around what are the gaps that are out there and how do we start kind of filling some of those gaps for data. So just wanted to say thank you for that.
Thank you. I think if there aren't any other questions or immediate reactions, we're happy to keep updating this. It seems like you are generally okay with this direction that we're moving and the process with the committees. Jeremy, do you want to talk at all about this as connection to the waiver, or do we want to hold on that till the next agenda item?
Well, I'll just say, just broadly, I kind of hinted at it earlier, but there's a lot of overlap here with other places where we've talked about needing to keep an eye on negative consequences or unintended consequences. This came up during CCO 2.0 with value-based payment. It's as we get into waivers, we'll talk about later, one of our key strategies is really advancing a global budget, and it's going to come up there as well. As we're trying to get the system to live within a budget, whether that's sort of value-based payment or global budgets at the CCO level, or the statewide cost growth target, there's, the similar concerns around sort of negative impacts. So we really want to thread those together and to the extent possible, create sort of common ways that we're measuring this, and not, we're going to do it one way for value-based payment and a completely different way for global budgets and a completely different way for the statewide cost growth target. Probably easier said than done. But we're at least approaching that on the outset, that we want to try to create as much alignment here as we can and not say, well, we want to measure unintended consequences for Medicaid in one way, but in a completely different way for value-based payments and a completely different way for the statewide cost growth target. So again, probably easier said than done, but that's how we're approaching it.
Any other reactions or questions for us on this?
Great.
All right, thank you so much.
Thank you for the presentation and discussion. So we are at our break. We're doing well on time. We'll take a 10-minute break and then come back at 10:20 for public comment. So we'll see you all at 10:20. About public comment, we as the board really welcome and appreciate the public testimony. It's one of the most powerful ways that we can demonstrate listening and learning from public. And then deep listening, though, requires that we won't respond to what you say, but we will reflect on it and discuss it with staff, bring it into our awareness and understand it's really important for our continued discussions and deliberation. So we won't be able to respond in real time, but please know that your thoughts are taken in and discussed and considered in our deliberations. Each presenter is given 2 minutes. In the event that doesn't feel like enough time, we encourage you also to provide written testimony, supplement your oral testimony, which we will also read. To keep us on time, we'll have a 2-minute timer for each presenter. We ask the presenter conclude their presentation when the timer is complete. Please know that both written and the verbal comments will be discussed by the board chairs and staff. For this April public comments, we're testing on a new process where we've had public sign up on the website that's linked to the Oregon Health Policy Board website. And we invite presentations or invite public to reserve a spot for public comment. And we ask them to provide notification within 48 hours or 48 hours prior to the board meeting so we can get you on the agenda. And today we have public comment from John Mullen, who's requested to present verbal public comment on the health equity definition. Mr. Mullen.
Thank you very much, Mr. Chair, members of the committee. For the record, John Mullen. Although I'm involved with a number of different organizations, I'm here on my own. I have 45 years of experience in human service work. For those of you who know me, who may be shocked at my appearance, I am waiting for the governor's emergency order to expire, hopefully on May 3rd, so that I can trim up and get back into society as we know it. A very quick sort of segue too, just to say thank you to OHA for making the portal that I went through to get my vaccine so easy to deal with. I have my second shot today, so I know there's been a lot in the news about the difficulty with implementation. My implementation was fine. So today I'm just going to be very brief, talk about my gratitude for the discussion about age being added to the health equity statement. So today I simply want to support that addition. I testified about this issue to the Health Equity Committee. I was pleased with the decision that HEC made to submit this update for your consideration. Adding the word age is an important recognition for older Oregonians, as this is a population that has significant health disparities, something I don't need to tell you with all the issues about COVID as one example. But I want to thank the HEC, and I also want to particularly thank the Office of Equity and Inclusion Director, Leanne Johnson, for a number of conversations with her good work, and for giving me the opportunity to testify about the issue of age in testimony at the Health Equity Committee. So in conclusion, I would just say I'm hopeful that the Oregon Health Policy Board will approve the recommendation to add the word age to the statement. And with this change, I will be enthusiastically supportive of the health equity definition, which I believe particularly around power sharing and resources is a really excellent statement. And with the word age included, it will then be complete as far as I'm concerned. Thank you for this opportunity.
Thank you very much. We also received 2 written public comments that I will read to you all because we're good on time. We received one public comment from Tamara Blackwell, who's a family involvement manager at the Oregon Center for Children and Youth with Special Health Needs and Oregon Family to Health Information Center, and also on the Medicaid Advisory Committee. And Tamara Blackwell says, much appreciation to the Oregon Health Policy Board for the inclusion of age into its policy statement. While I'm supportive of that change, I feel race and ethnicity should stay at the top of the list, and I recommend that the wording be, quote, Oregon will have an established healthcare system that creates health equity when all people can return to their health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender, gender identity, sexual orientation, social class, age, intersections among these communities or identities, or other socially determined circumstances. We had a second written public comment submitted by Miguel Angel Harada, health equity and diversity strategist at Pacific Source Health Plans, and also a Medicaid Advisory Committee member. And Miguel Harada says, I like the advance on this definition. However, I disagree on the phrase, when all people can reach their full health potential and well-being. I would like to include something more objective that will put the responsibility directly on the system, something like health system that creates health equity by making DEI a priority, dedicating resources, creating policies and procedures, and being accountable to deliver the services in a way that will allow all people can reach their full health potential and well-being. Without dedicated resources, policies, practices, and accountability, there will be just another declaration. And I feel that this is trying not to be that, but something is missing. I don't know, my 2 cents. Thank you, Miguel Harada. So we'll conclude public comment, and go on to a discussion of our health equity definition. We have Leanne Johnson, the director of OHA's Equity Inclusion Division, who will join us on behalf of the Health Equity Committee today to share an updated definition of health equity that's being put forward. This is an item that's being put forward for discussion as well as vote and potential approval by the board. So Leanne, please.
Thank you. Thank you, Chair. Thank you for the opportunity to be here. For the record, my name is Leanne Johnson. I'm the director of the Equity and Inclusion Division for the Oregon Health Authority, and always a pleasure to follow John Mullen. Appreciate his advocacy on this matter very much. So the definitions is there before you, and we just wanted to give you some background. I am here on behalf of the Health Equity Committee and our 2 co-chairs who are unable to attend today, Dr. Derek DeVivier and Kate Wells. So they send their regards and their regrets. But as we know, and this was stated in testimony, that COVID-19 has amplified both our deficits and our needs, and hopefully some of our strengths as well. And through seeing how COVID-19 was initially impacting older populations of people and continues to do so in many respects, it was important for the Health Equity Committee to take under consideration the recommendation to include age in the health equity definition. We received the thoughtful feedback from community, from Mr. Mullen, to include age, and we've interpreted that to be age related to our elders. We also received feedback from the Medicaid Advisory Committee to consider including age on the full spectrum of age to better encompass the fact that children on Medicaid are subject to greater inequities due to structures and systemic matters of racism and discrimination and oppression. So their interest was including age from the standpoint of inequities and the intersectionality at race and ethnicity, poverty, and of course, age. So the Health Equity Committee took that all under full consideration, did not take it lightly, did not want any changes to become a gateway that would diminish the impact of this definition. Appreciate the feedback of where age might sit in this in the text itself, to understand the significance of race and ethnicity as a primary a way that people are very disadvantaged due to racism and discrimination and longstanding oppression of 529 years. So it was really critical that we not see this as opening the doorway or as a way to provide an off-ramp to the very critical conversations around race and ethnicity, but to understand that there is something that we need to take note of and acknowledge and work toward equity around age across the entire spectrum when it comes to the health of people in Oregon. So just want to be really clear, we did not take this lightly. There were several months of research and deliberation by the Health Equity Committee, and the vote was taken. It was not a unanimous vote, but a majority vote to include age. And that is today the recommendation that comes before the Oregon Health Policy Board from the Health Equity Committee to include age as one of the determinants of health inequities, and therefore one of the determinants of focus when we continue to move forward to eliminate health inequities in the state of Oregon by 2030. I believe I will stop there. Take any questions or comments that you may have. Thank you for your time.
Thank you, Director Johnson. We'll open up for discussion.
So this is Ebony. Thank you, Leanne, to you and your team just for your responsiveness, thoughtfulness, thoroughness, intentionality, and just really working to integrate, you know, all of the various kind of perspectives around feedback and input. And I know, and so I'm saying this out loud to check myself, because I know that, you know, when you start looking at these types of definitions, you can take a whole year or more to wordsmith. And it's about the action and the commitment and how that's realized through, you know, all facets of the work. But I will just say one thing that like I'm grappling with is, you know, I think based on that written testimony where someone was talking about, you know, the responsibility, that definition, as you read it, you could interpret it as it's the responsibility of the individual to reach their full potential when the issue is the barriers that are created by the system. And so I was almost wondering, like, you know, do you throw in there, oh God, can we put the definition up one more time on the screen? I should have wrote down my thought, I'm sorry. Because it's, because in my opinion, I think that, you know, one core issue is that folks are disadvantaged by the system. So I almost want to say, you know, so when people have, you know, pathways to receive their full potential and well-being, and are not disadvantaged by systems and or race, ethnicity, language, And we're not here to wordsmith, and I know that we're probably in the 9th hour. So I'm just sharing my thoughts out loud, and I just appreciate the hard work. So thanks.
May I respond?
Please.
Yes, yes. I thank you, Ms. Clark, because this is another conversation that has come to us as well. And I'm more than happy to take this back to the Health Equity Committee. And the conversation in part that has started a very, very minimal conversation, because we were really focused on the age part of it, is that it's not for our race or ethnicity or any of those other dimensions that create the disadvantage. It is the impact, it is racism, it is discrimination, it is oppression, it's how those attributes are treated in society. And so perhaps some rewording there would actually absolutely be warranted. More than happy to take that back, and have that conversation, and also get any more information from you that you'd like us to potentially discuss around that. But understood, I'm understanding it from my own context, and please correct me if I'm misunderstanding what you're bringing forward. Hear this loud and clear.
No, I think you captured it. Thank you.
Thank you. Thank you.
Vice Chair Rana, you had some thoughts you wanted to add?
Yeah, so I just want to say, echo some of the comments that Ebony already expressed. The public comment kind of perked my ears sort of that way as well. I thought about that. So the other thing, I just kind of, as I was looking at this definition and we were talking about, these social determinants, I noticed that legal status is not included in there. And I was curious if the Health Equity Committee has sort of discussed, immigration status as something to be added or included in the definition. And I also heard that we don't want this like addition of age to sort of like open the floodgates to like add a whole bunch of things. But I'm just kind of curious to hear about that consideration, and as well to hear a little bit about the vote that you just mentioned that, was not unanimous, but it was kind of a majority. I kind of want to get more idea of like how close that vote was as well.
Okay, thank you, Vice Chair Rana. So to answer your second question first, I will not have the details and can get back with the committee, with the board on what that vote was, because I saw percentages. I think the percentages worked out that maybe one person was opposed, but I'm not, I would just need to go back and talk with Maria Castro to get those actual percentages. And when we moved through the deliberation, the biggest concern was this, as I mentioned in opening comments, was this change being that opening the door. So it wasn't the deliberation piece of it anyway. Don't know if this was reflected in the vote, was if we do this now, where will this end? And so that might be the reason there was the nay vote. I don't know that for a fact, but that's something I'm pulling together in my mind as a possibility. So there's that. And then please restate or say again the first part of your, it was about undocumented individuals and immigration status. That was a conversation, and once again something that we can also look at without making any foregone conclusions about where the Health Equity Committee will land on that. And if it's coming forward as something you would like the Health Equity Committee to discuss, we can certainly do that.
Sorry, Brenda. I mean, I think, as we're talking about alignment, of our definition, an alignment of our other priorities, there's a lot of conversations happening about cover all people. There's a lot of conversations about universal healthcare, trying to get as many folks to have access to healthcare. And to me, it seems like immigration status is probably a really big barrier.
Thank you. Once again, more than happy to take both these matters back to the committee.
Brenda, do you want to chime in?
Oscar said it so perfectly. I have nothing to add. Thank you.
John, Kirsten, thoughts you want to add to the discussion?
I have one small question, just also piqued by the public comment. Age was inserted kind of in the middle. Was that a purposeful placement? Or can you talk about why it got inserted into the string where it did?
I don't, and I really can't speak to that. I'll be really honest from the standpoint of I don't recall any specific conversation that we had actually in the meeting of where it would go, and perhaps there was and I missed it. I can go back to the minutes and double check, and also check in with Maria Castro. The detail that escapes me.
Come back. I was curious more than anything.
I'll make a note of that. Thank you.
And, all I would add is I'm happy to see its age. So it can be any age. I know there's a lot of folks who feel pretty strongly that children have been discriminated against in our health system for decades. And and they're oftentimes not a priority. You know, as a Medicare person now, I'm actually surprised how much my lower income 70-year-old friends are paying for their health care. You know, that Medicare really is a healthcare system that requires a lot of revenue from the members itself, and can be quite the challenge for you know, again, that lower middle income group. You know, a lot of lower income Medicare folks are also on Medicaid. It's all ages, and it's a challenge. I mean, I'm doing the 770, and Oscar kind of mentioned universal care, and it just is so challenging, the system we have that just creates so many opportunities for inequities, because who we cover is variable. How much they have to pay to cover is variable. What benefits they get is variable. It is just so messy. You know, hopefully we can see something better in our lifetimes.
Appreciate that, John. I think, you know, certainly COVID has shown us the differential impact of older age and those inequities. But yes, it's also really important to keep track of, you know, Oregon's investment in Cover All Kids, and, you know, made a very intentional effort to reduce inequities amongst very young people.
Yeah, and you know, David, I can't help but, I mean, seniors were clearly prioritized, as one might consider they should be based on the evidence, but there was no priority that really appeared to be possible based on race or ethnicities. Mm. You know, it seemed like there should have been a more overt priority on you know, older folks whose race and ethnicity likely was a barrier, but that was difficult to do. And so these are really tough problems.
Let me check in with the board members. What I'm hearing from you all is that there's general support for the inclusion of age. We might be ready to move forward for a vote with, you know, additional discussions with Ebony's point about, you know, emphasizing pathways in the role of the system in creating those pathways for people to achieve equity or realize equity, realize their full potential. That's a responsibility of the system and an appropriate pathway rather than on the individual. And Oscar's appropriate comment about, you know, looking at immigration status or legal status as further deliberation. But what I'm hearing from you all is support of adding age, but let me just check in to see if there's any concerns, further discussion about adding age. Kirsten, did we?
I'm fine with that. I am moved by the like placement of age comment, and do appreciate that the definition kind of maintains, I'm remembering correctly, race and ethnicity at the beginning. So.
Director Johnson?
Yes, thank you. And if Chair Bangsberg, if there is a recommendation that the Oregon Health Policy Board has about placement, I think we would be more than open to cover that today if there is a recommendation for placement based upon I'm sorry, I'm losing my words today, based upon the feedback from community. Thank you.
Are there comments regarding placement?
I'm okay with where it's at, but at the same time, it would be fun to actually have the this align with our real D and SOGI sort of terminology, so that when, we kind of like get this real D SOGI terminology kind of out there, as well as we're trying to make sure that providers also like adopt these things. But I guess I'm okay with where it's currently at.
That there would be elegant policy to achieve such parsimony. All right. Then, pending any other discussion, do I hear a motion to vote for approval for the inclusion of age, pending pending discussion that has been brought up around pathways and legal status that would go back to the health policy or go back to Health Equity Committee?
So moved.
I hear a second.
Second.
Okay. All in favor? Aye.
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 Any opposed? And any abstain? Director Johnson, it passes. Thank you very much for the presentation, and thank you to the board for the discussion. And obviously this is a discussion that doesn't have an end. It will always continue. So we'll look forward to further discussions around this definition and also how best to implement this definition.
Thank you.
We are doing well on time. That's great. So the next item on the agenda is to have OHA leadership share updates on their work for the upcoming 1115 waiver renewal application. This is included in attachment 7, and I think this discussion will be led by Jeremy Van de Hey.
Great, thanks. And actually, I'm going to immediately turn it over to Pat and then to Trilby, and then I'll pick up the second half.
Thank you.
Thanks. So what we're going to do today as we give you this update is cover just a little bit of overview and background on all things waiver. We've had folks come and go from the board, and some of you are well versed in this, and others perhaps a little bit less so. So we want to do some level setting. We're going to talk about where are we in terms of process, focusing especially on what are the relevant timelines in the public input process. We'll talk about your role and have a discussion about that. And then we're going to talk about how this fits in the larger policy framework of the Oregon Health Plan and trying to deliver the triple aim. And then we're going to take do a deep dive topic around eligibility and coverage. And I think what you'll see as we come back with each of these is kind of a rotating set of those sorts of deep dives as we go into specific areas. Next slide. There we go. So a few things that I want to just sort of generally comment on about the waiver. First, the really important thing to understand is that the waiver is an important and useful tool to try to tailor Medicaid to the needs of Oregonians and to our approach for advancing the triple aim and providing access to health and healthcare. It is, however, not magic. You can't do a waiver application to make money suddenly appear where none exists, although there have been times that there have been the offer of funds attached to a waiver to be able to spend more, but it doesn't make money appear. And in fact, a waiver generally has to be fiscally neutral to the federal government, and that's part of what we have to demonstrate in our application. And it can't make whole sections of federal law disappear. What it really is a way to, as I said before, tailor the way Medicaid works in Oregon to meet our needs, and it fits in with a bunch of other tools. When I first got to the agency, we were working on CCO 2.0, which was a huge body of work that many of you participated in. That was really aimed around how do we shape things like our incentive systems and contracts with CCOs and all those kinds of things, and that was all done after the waiver. The waiver that we're currently operating under. So I want to just kind of set that context of waiver is an important tool, but it's not the end all be all of how we manage Medicaid in the state. Governor's given a directive and articulated kind of the principles that she would like to see us follow in the waiver, and you can see them here. I won't read them out loud to you, but I want to just point out, given the conversation that we had before, that the first of those principles is health equity, and that's really consistent not only with the governor's direction, with your expectations around equity. It's also consistent with the agency's strategic objective of eliminating health inequity by 2030. I think increasingly you're now seeing everything that we do start within the context of an equity framework, and how does the work advance equity. The other thing to emphasize, in addition to these principles, is that at the end of the day, what we're going to be working on is an application for a renewal of our waiver. There's a lot of work to do. We need to make a strong case, but ultimately it is CMS that will make a decision about whether and how to approve our application. And usually there's an extended period of negotiation around that as we work through that. Some of the well, I'll get to that in just a second. One of the things we've really tried to focus on over the last couple of years, and again, going back at least to the CCO 2.0 process, is extensive community input. We kind of re-kicked off some of our community input around CCO 2.0, and we've really begun to pivot and think differently about how we engage with communities in a more authentic manner, to be able to get a lot more ground level input, in this case in particular, about how the Oregon Health Plan does or doesn't meet people's needs. And so one of the things we've heard fairly loudly and clearly is some sort of a version of, we keep telling you what you need to go do. Don't keep coming back to us asking us what to do. Go do what we've told you to do. And so that's really part of how we're trying to build this application, is to incorporate that input and feedback that we've been receiving pretty consistently. Now we've got clear messages out of that. We think we've got some good direction. We'll continue to have public input through this process and community engagement, but we're going to start foundationally with what we've already heard and learned from the communities that we serve. With that, I think I'm ready to go ahead and hand it over to Trilby.
Thank you, Pat. What I'm going to do now is take the board members through the process, and I'll do this briefly so that we can get into some of the content development. Next slide. This gives you an overall look at the timeline, and you can see that we're really coming out of a period of talking about vision and goals. And as Pat said, it was so important here to build on the community input that we've been receiving, through the listening sessions that happened around CCO 2.0, through the COVID listening sessions. There's really been quite a bit of feedback from community around OHA's strategic plan as well. So we've been going through that. That's an ongoing process, and that's really the foundation for how we've been identifying vision and goals. And we've been engaged in some project planning just coming out of that, solidifying staffing, et cetera, and coming into really what we call phase one, which is the application development and then the submission. And as you can see, there's a couple different phases of public engagement as we develop the application and then submit it by the end of this calendar year. Phase two, really starting in 2022, is the negotiation and approval process, the formal negotiation and approval process. There is some negotiation that goes on with CMS during this phase one as well, after we begin to share concepts with them. But the target then for our approval is June. That would begin the next period of the waiver. What's out of scope for the project that we'll be talking about with you today is really the implementation of the waiver. And that takes place after we get that approval. Next slide. Goals for engagement. We really want to continue to build awareness and understanding of the goals as we've been developing them based on community input. We will be engaging with tribes. We've begun that already. That's early and often. That's a co-creation process. And then we're gathering feedback on our renewal goals and on the initial content from interested stakeholders, and really working with them to hone in on what the strategy should be in the waiver. And in this way, in all these touch points, we lay the groundwork for support. We're really looking for the support from the community and from the different stakeholder groups and tribes for the final waiver package. Next slide. So in putting together our community engagement plan, we've been looking at different audiences, and this slide gives you a sense of how the different buckets of audiences that we've been talking about. As I said, with tribes, it's a co-creation process. We've got monthly tribal meetings. We've had a kickoff conversation with the tribes. I believe there's another one coming up this week. And all of these monthly conversations lead up to the formal tribal consultation that takes place a little bit later. State policymakers, I have another slide on this immediately following this one, so I won't go into any detail on that right now. But just to give you a sense of some of these other buckets, industry stakeholders, no surprises here, this will be the CCOs. The Hospital Association has asked for meetings. Behavioral health providers will be very important to hear from. Primary care. Community is, of course, a very, very important bucket for us. As Pat said, we've been tapping into existing input. Our community partner and outreach program has monthly meetings with local groups across the state that include providers and members. And those will be really important venues for us. We'll be on the agenda for a lot of those meetings. We are engaged in a conversation right now about the best way to engage with the regional health equity coalitions. There's a couple different places where members, representatives from the RHECs are on different committees, and we may work through one of those health equity committees, or we may have independent meetings with the RHECs, but they're a very important group for us to be hearing from early and often, as are the CCO CACs. They have monthly learning collaboratives, so we'll be utilizing those meetings to get input and do educational sessions. Behavioral health feedback, we know we're going to be getting that throughout, and then we have a couple of specific opportunities to work through the Oregon Consumer Advisory Council and the Children's System Advisory Council, among other behavioral health specific communities, to hear from community members. Then we are going to also reach out to organizations that work with specific communities or populations, groups that work with persons with disabilities, communities of color, older adults, LGBTQIA communities, and rural communities. And what we're thinking there is to do an educational session where we can really get people up to speed on, again, the goals, visions, the emerging strategies, take input, answer questions, and clarify pathways for public input. We have a webpage that's launching shortly, and that will play a major role for us in sharing information and collecting input. So finally, just to tell you about the last bucket there of federal and national stakeholders, there's a lot involved in that bucket as well. We have basically a 5-point plan. We've got our congressional delegation, that's number one. We've got the federal agencies, CMS and the White House, their Office of Domestic Policy Council, national advocacy groups, some really important groups to work with nationally, congressional advisory bodies like MACPAC, MedPAC, groups like that, and then also congressional committees. There's quite a few key congressional committees that will need to be educated and whose support we'll be seeking. So that's at a high level. This next slide, if we could move on to one more, this gives you a sense of the bucket that I neglected to speak to. This is state policymakers, and this is really where we see you all leading the charge. You are a major policy advising board, and underneath you sit the Medicaid Advisory Committee and the Health Equity Committee. And we're thinking that all three of these are really important touch points for us to ensure, as OHPB has been charged by the governor, to ensure that we've got alignment with CCO 2.0 goals, and that we're really stewarding how providers are engaging in the process, and that health equity is guiding us overall. Medicaid Advisory Committee is a fantastic opportunity to get consumer input on whether we've got enough consumer protections, whether we're really looking at negative consequences, shall we say, of policies that may end up in the waiver. And then the Health Equity Committee. We're going to be meeting with them later this week to talk about potential roles for them. I believe there's a lot of excitement about doing health equity analyses and potentially also convening a little more broadly to include some members of the Health Equity Committee that sits underneath the RJC. We've actually got 2 health equity committees in operation right now, and we're trying to find a way to bring them together for the waiver input. And then finally, there is a specific legislative work group. This is a small group of key legislative leaders put together by the Speaker's office and the Senate President to meet with us early and often about the waiver. And I believe we've already had, it's either 3 or 4 meetings with this group, and those will be ongoing as well. So deep breath, it's a lot of engagement. It's starting to really come together and gel as a plan that we can all get our arms around. And we are looking forward to keeping you abreast of what we're hearing from everybody. I'll stop here. Oh, actually, no, I've got a few more slides. My apologies. Next slide. Wanted to hone in on your role with, next slide, with these categories that hopefully look familiar from the retreat. Let's see. I think we need to go back 1 slide. There we are. We've got you leading here on alignment with CCO 2.0 and opportunities for committees to engage. This is where we really need to hear back from you. Are we getting this right? And I know we've had some conversation one-on-one with each of you already about the policy goals in the waiver, and there'll be more on that from Jeremy. Really want to hear back from you. Are we getting the alignment with CCO 2.0? And likewise, this engagement using both the HEC and the MAC, does this make sense to you all? Is this a good way to go? Leading there and then collaborating with us, lending your expertise. Again, we've been already reaching out to you one-on-one, giving us your input on what the committees are telling us. We'll be coming back to you with that. Supporting the vision. We're working toward that, hoping that we have your support on the application, and then helping us to communicate out on project status, timelines. By this presentation today, you're really fulfilling that function, sharing information about community engagement opportunities. So these are the ways in which we see your role in multiple iterations on waiver. And last slide for me is, I think I covered some of this in what I just said. These are really examples of how you would be acting in each of those roles. You'd be getting updates and input. We'd be consulting with you individually. That's the collaborative role. And you would have these strong connections with the work through your committees. And that is a leadership role through the committees. Now I believe I am truly done. Yes, and ready to hand it over to Jeremy, but I'll pause to see if there are questions on process or board role. That's great. That's kind of amazing. All right, hand it over to Jeremy.
Great. Thanks, Trilby. And Lori Corner, our State Medicaid Director, is on as well. And I'm gonna do most of the slides. She's gonna fill in some color commentary. There's 4 areas of the waiver, which you'll see in a second. And I think, Dr. Bingsberg, if it's all right, they blend together a bit. So I think it'll be easiest if we plow through all 4 and then pause for questions, because I just suspect folks will wanna jump ahead. Next slide. So our overarching goal for the waiver, Pat showed the principles early on. We've been continuing to refine kind of vision and major priority areas with the governor's office, as well as with a small work group of legislative leaders that we've been working with over the last month. And we've really honed in on and I don't think any of this will be a surprise to folks, but the overarching goal surely should be to advance health equity and ensure that the waiver, while only one piece, is an important piece to advancing the agency's 10-year goal of eliminating health inequities by 2030. And again, it's only one piece, but I think that the whole waiver really should be grounded in that vision. And then we've got four kind of priority areas within that, which I'll run through. Next slide. The 4 areas, and I'll go through these in more detail, and then we'll pause for questions. First, really advancing and creating a health equity, an equity-centered system of health, and making sure the health system is really centered and providing and advancing health equity for members on the Oregon Health Plan. Second, ensuring that the waiver fits as part of the broader statewide goal of getting to universal coverage and ensuring that all Oregonians have access to high-quality affordable healthcare. Third, really encouraging smart, more flexible spending to be able to address things like social determinants of health and health equity. And fourth, as we're trying to achieve savings, seeing if there's opportunities to take, sharing some of those savings with the federal government and make some strategic targeted investments into areas where we know we specifically need to plow some dollars and to address health inequities. So those are kind of our four broad areas, and there's a lot that can fit underneath each one of those. Next slide. What we're going to do is, for each of these areas, talk a little about kind of the vision, problem vision. As Pat and Trilby mentioned earlier, we're really approaching this from the standpoint of trying to dig back through input that we've heard from the community over the last couple of years. We don't really want to go out to folks and sort of act as if we haven't been hearing a lot of the same issues over several years. So we're looking through input we've received through the State Health Improvement Plan, through the agency's strategic planning around health equity, the CCO 2.0 input, and others. And so there'll be some examples in here, some quotes that we've received from the community that we think help tee up some of the challenges. First, on the health, an equity-centered system of health. Ultimately, our vision is we have a health system that works for all people in Oregon, and we really need to make sure that we continue to transform Medicaid to improve the experience of all members, especially those with complex needs, and really that we recognize and address the inequities, lived experiences, and barriers that lead to health disparities. The waiver is not going to solve all of these. To Pat's point earlier, we're looking for opportunities where we can get some flexibility, usually pretty targeted flexibility that really help us push towards this vision. And so the hard work comes afterwards, and a lot of the work that we need to achieve this vision is really outside the waiver, but we're looking for those places where we can get some additional flexibility. And to give you some examples, thinking about how do we create more continuity around the behavioral health system? How do we provide some more continuity of transition of care of people moving in or out of Medicaid and other systems like the state hospital or public health? How do we continue to find opportunities to cover non-traditionally covered services, culturally responsive services? It's come up a lot with tribal communities who have developed evidence-based practices that aren't always covered under a sort of traditional medical service. So looking for those places where we can get some additional flexibility from the federal government. Next slide. Is, I think, probably not a surprise that we see over and over again folks identifying racism within the system and inequities. I won't read through these quotes, but to give you examples, clearly we've talked about this a lot on the board. There's clearly issues related to language barriers, culturally responsive care, I think the quote at the bottom right here, it's a surprise if I am treated well at the doctor. There was a story, I can't remember if I shared with the board a couple months ago, that in Mexico there was actually a practice of separating babies from mothers if the zip code was associated with a zip code that was associated with a tribal community until there was a negative test, only for those populations. And so we know that there's racism within the system, and we know that there's a lot of inequities, and that we have seen throughout CCOs that where we make improvements in quality, we see that the inequities and disparities persist unless we really center health equity. And so that's where we really want to be focused on is recentering the whole system on health equity. Next slide. So our future state here, we want OHP members to really experience, all OHP members to really experience a highly coordinated, integrated system, and one that coordinates both across healthcare and social systems that ensures that that folks can receive the care they need without language or cultural or economic barriers, that enrollment and care is continuous and seamless across systems, and that we continue to push on getting folks the things that they need that keep them healthy, even if that's not healthcare, and if that could be housing or social supports or other services. Lori, anything to add here before I move on?
I don't think so, except that I do want to highlight kind of that last bullet around that Medicaid will be seeking a request that Medicaid cover housing supports and social supports for members who have complex needs, and that can be complex physical, behavioral, and social needs. But looking at those members that we aren't meeting their care needs or their social needs in order to remain healthy.
Great, thanks. All right, next slide. The second area is around, and we'll talk about this later if we get time, around the broader deep dive into eligibility, but thinking about how the waiver fits into the broader goal of the governor and legislature to keep pushing towards universal coverage and ensure that all Oregonians have access to high quality, affordable coverage. Medicaid's only a piece of that, but there are some opportunities we think to look at how do we stabilize coverage for folks, especially those at risk of becoming uninsured, even though maybe they actually are eligible. And can we take some of the lessons we've learned through the pandemic where we've paused redeterminations and see if there's places where we would want to make some of the flexibility we've gotten through the pandemic permanent to make sure that folks who are eligible for OHP stay in and don't fall out. Next slide. This quote on the left, being one paycheck away from being overqualified for the Oregon Health Plan, I think highlights the issue that we've seen quite a bit, that there's a lot of churn with relatively a lot of churn within the system, folks moving back and forth between the Oregon Health Plan or marketplace coverage or Oregon Health Plan and employer sponsored coverage. It is just a larger issue now that since the ACA has passed, that OHP really is the source of insurance for low-income workers in the state. Most of those folks don't have access to employer-sponsored coverage otherwise, and so as their income fluctuates, sometimes they can be relatively small changes can move them on and off the Oregon Health Plan. I want to be clear that access is obviously critical, and there are a lot of access issues within the system. Being covered and having insurance is sort of the first step. A lot of the access issues, and we do hear quite a bit of those, frankly, a lot of those are local issues, network adequacy or prior authorization issues. So that's not in here largely because those are frankly on us as we administer the program and not necessarily things we need flexibility from the federal government on. But we do think that there's some opportunity to really take a look at our eligibility processes and think about ways that we really focus on preserving coverage. The Ombuds team just put out a report of annual complaints and eligibility issues where they're tied for their top area of complaint. Next slide. I think you've seen a version of this before. We've gotten to the point of only 6% of the state being uninsured, but there's enormous inequities when you look at that data broken down by race and ethnicity. The uninsured rate for Hispanic Latinx communities is 12%, 11% for American Indian Alaska Natives, 8% for Black African American. Our data has shown these numbers are probably going to go up 2 or 3 percentage points for communities of color. And so we had big inequities pre-COVID, and it's going to get worse. Within Medicaid, again, Medicaid's only a piece of this, but we've been tracking the number of folks who've been coming into the Oregon Health Plan now that we've paused redeterminations. We've had about 200,000 folks come into the Oregon Health Plan and stay since the pandemic. On average, pre-pandemic, about 8,000 folks were enrolling each month who had been enrolled at some point in the last year. So nearly 100,000 folks were coming in each year who had been enrolled at some point in the last year. And so what that tells us is there are a lot of folks who are either teetering on eligibility or they are eligible, but they aren't reapplying because of issues with the process, or it's confusing, or they've got too much else going on in their lives. And so they leave and then they come back when they need a service. And so we want to look at ways that we help smooth some of that out. Next slide. So future state, we want to make sure that folks who are eligible for OHP get in and that they stay in, and we reduce the number of folks that that are falling out unnecessarily. This will be a particular issue as we're thinking about the 200,000 folks who've come in during the pandemic. If their income is slightly above OHP, there's a good chance that they're eligible for the marketplace. And so I think one area in particular we want to focus on is let's make sure that we don't, at the end of the pandemic, just suddenly cut off eligibility, that we've got a smooth process that if they're eligible for marketplace or they're eligible for the Oregon Health Plan, the federal government's picking up a large part of the bill anyway. So let's make sure we've got a process that's aimed at primarily keeping those folks insured and then getting them to the right place of what they're actually eligible for. And obviously looking through where we've got inequities in coverage is really important, and thinking about how do we close the gaps on some of those. An area that in particular we want to think of through with the federal government is if there's opportunities to take any investments that the legislature makes and cover all people, and couple that with any additional federal resources to provide more comprehensive care to folks who aren't eligible due to immigration status. That's traditionally been an area that's a pretty hard line for the federal government, but they actually do cover emergency services. So we want to think through if there's some opportunities to couple state and federal dollars to provide the full benefit for folks. Lori, anything you want to add on here?
No, I will. We have learned a lot with during the pandemic. We've been, as Jeremy mentioned, we've added about over 200,000 members to the program. And when I say that, actually, most of those are people who are not dropping. So right now, if a person, it's up time for them to reapply. If we don't hear back from them, we are keeping them on OHP through the pandemic. And so we know, it's telling us a lot about the churn. It's also telling, and that there's a big cycling of people coming on, as Jeremy mentioned, where they drop off and then they come back. So those are important pieces for us to learn from and then make bigger requests through our waiver application. And the other thing I'll mention is we've added some flexibilities to there's some emergency coverage for people who based on their immigration status. And for example, we've been able to allow those individuals to have, COVID testing covered and vaccines covered. And so we want to continue to expand that sort of coverage for all Oregonians. That's all I have, Jeremy.
Thanks, Lori. Okay, next slide. So the third area is around more flexibility and ability to spend on services that really support health and health equity. We've talked a lot about this through CCO 1.0 and 2.0. That we have continued to push on trying to get more flexibility on what Medicaid can cover and how and what we can count in the rates that we pay CCOs in terms of last year's spend on things that are outside of traditional healthcare services. Obviously, first and foremost, we want to make sure that CCOs are covering all of the services on the prioritized list that folks are eligible for. But we know that often the thing that somebody needs isn't a traditional healthcare service, and we want to focus on more of those, and focus frankly on the system investing in places that keep people healthy, and that saves downstream costs. Next slide. Through lots of community engagement over the last decade, you all have heard, I think, a lot of examples of folks needing supports around food, around housing, around other social services that frankly the healthcare system isn't positioned to solve maybe statewide for all folks, but oftentimes there is a specific situation where it would be cheaper and easier and better for a member to get them the housing or the transportation or the other types of services that they need to be healthy, and that when the system doesn't do that, folks end up in the emergency room. They end up with health issues that get exacerbated, and we certainly hear this continually from members in the community. Next slide. Next slide. So future state here, this is really going to be about pushing even more so towards a true global budget. And what I mean by a true global budget is there were really two components of the idea of a global budget when we stood CCOs up. The first was blending all the funding streams into one payment rate to CCOs. Previously, physical, behavioral, oral health was all separate. And we did successfully, for the most part, blend all that together. There are a few things that still are outside, but those physical, behavioral, and oral health dollars have all been blended together for CCOs. And the idea was to really provide maximum flexibility and accountability for those dollars. The second piece was really to have the amount that we pay CCOs grow at a fixed, sustainable rate of growth and adjusted for things like risk, but largely looking like a budget that this health system needs to stay within. And that's where we really run into some challenges with the federal government. They largely require that states primarily set their rates for CCOs based off of last year's spend on healthcare services. And we've gotten a lot of flexibility through the 2012 waiver and the 2017 waiver to count things like health-related services and to encourage more of those. But primarily the rates still have to be based off of the previous year's spend on healthcare. And that just seems to lock in the sort of continued incentive that it's still sort of better for a CCO from a rates perspective to be spending on healthcare instead of non-healthcare services, because they can see that show back up in their payment next year. So we really want to move further towards a system that is paying a budget that's based off of historical spend, but grows for a period of time, primarily based on our fixed rate of growth and things like a risk adjustment, but that isn't rebased every year or two, and really encourages the system to make more upstream investments that they'll see a payoff down the road for. I want to be clear, we're not expecting that CCOs sort of solve all things social determinants of health. But we do think that there's a lot of opportunity to be able to have a more flexible payment model to get folks the thing that they need that's going to keep them healthy. Lori, anything to add here?
Oh, the only thing that I would add is that we also want to encourage that the community investments that are made by CCOs are held by the community. We've learned a lot about how to engage community in how those investment dollars are spent, and so we'll be seeking more of that across our system in the future.
Thanks, Lori. It's the we'll go to the next slide. The fourth area, and I'm sure there's a lot of questions. I know I'm kind of plowing through this. I just wanted to make sure we get to discussion. The fourth area is around reinvesting any savings that we're able to achieve back into areas that really target reducing inequities and promoting health equity. Senate Bill 889, the statewide cost growth target, if successful, will save a significant amount of money for both the state and the federal government. And the federal government, not just in Medicaid, but also in Medicare and federal employee programs in a number of places. Statewide, if we're able to achieve our cost growth target of 3.4%, which is the target, as opposed to the 5.5%, which is the federal projection, that's $16 billion avoided over the next 6 years across all markets. Obviously, that's not all savings to the federal government, but a lot of it is. And so we'd really like to find some opportunities to figure out if we can share some of that savings with the federal government and use those dollars really specifically to address health inequities. And details obviously to be sorted out here, but I think this is separate from the global budget concept, because the global budget is really around how the CCOs have more flexibility for the dollars they have and the population they have. But there's places where we just need to actually make investments directly into health inequities, and it sort of needs to be outside of just what we pay the healthcare system. And so that's really where we're thinking this comes into play. Next slide. A couple quotes here from community thinking about if there's opportunities for OHA to partner with parts of the system like Parks and Rec or community centers to really take a more proactive approach to health. Housing obviously is kind of front and center in our minds here, and all states have been pushing on housing. I think it's probably unlikely that we get to the spot of Medicaid just sort of covering housing broadly, but we keep pushing for flexibility to cover supported services. And we've been thinking about, is there a space here where we could push to get some housing investments that are really targeted at addressing inequities in the state. And maybe that's a place where we can push CMS a bit farther. Next slide. So, future state, what we really like to be able to do is come up with a shared savings arrangement with the federal government. When we did this in 2012, they made an upfront investment in the state that was really designed to launch CCOs, and the state was at risk for some of those dollars if we didn't meet our cost growth target. Here we're almost 10 years later, we've had a cost growth target, and we're now expanding that to statewide. And so I think rather than sort of an upfront investment to get CCOs started, what we're looking for is something that looks more like a shared savings arrangement, where as we reduce costs, we can keep some of those dollars and plow them back into places like housing or other areas that address inequities. Lori, anything you want to add there?
No, just to remind everyone that in our program, the federal government covers about roughly 70 cents on the dollar for each member. It varies by member type, but so they make a significant investment. So if we save money across our state, that's big savings for the federal government, which is where we would argue that we should benefit in some of those shared savings.
Yeah, and the only thing I just would add, and then stop for questions, is this is probably the area that's a little bit most ambiguous. Maybe that's not the right word. There was 2 programs that allowed states to pull down additional dollars in waivers, and both of those were turned off by the last administration. And we don't have a CMS administrator who's been confirmed yet, and we don't really know what this administration's policy is going to be on sort of getting states getting additional dollars through waivers. So we're planning for the ask. We have no idea whether there'll be a receptive audience to that, but we think it's pretty important to go in with the ask, and we think we've got a strong case on the shared savings. So why don't I pause there for any discussion or questions?
Thank you, Lori. Thank you, Jeremy. Comments or questions from the board? Oh, Brenda, go ahead.
First, I want to thank you. Oh my goodness, this body of work and the framing that you've done for us today is really powerful and exciting, frankly. Like, I'm sitting here looking at the detail and thinking, oh my gosh, finally, could we? So thank you for that frame. My comments are, if you could, or I guess a question is actually helping us understand where some of the largest constraints really are. Is that when we think about our application, we can think about it from the context of trade-offs, recognizing, as you both or you all have talked in the tee-up, that this isn't the end-all be-all cure-all for all of the woes of healthcare transformation. And yet there's some big heavy lifts and wins that we want to get, that we are really consciously acknowledging the trade-offs that we will either find a different mechanism to address or simply deal with a problem of that particular trade-off. So I wonder if you can help us identify out of the list of potential opportunities, those that you think have the biggest stretch, the biggest potential controversy, the ones that have the biggest heightened awareness from your perspective that we should be knowing about.
I'll jump in front of Jeremy and Lori and say that from my perspective, certainly the thing I've found myself talking the most about, and the thing that has come up most often as a barrier, is not having a true global budget. And compounded by the fact that some people think we have a global budget and wonder why we don't act like it. But I think that has kept us from reaping the benefits of basically providing flexibility and discretion to CCOs, to figure out how to manage high quality care and save money, and then not be penalized for saving the money, because the system we have right now actually penalizes CCOs for doing a good job of cost containment.
You know, I would say coupled with that, and I don't know, again, I don't know, I call it a trade-off, but it might feel like that to the health system, is that I think coupled with the global budget, it's going to have to be stronger accountability. You know, what CMS, what national advocates are constantly concerned with is that the global budget is code for some type of per capita cap or block grant, and concerns that if states put downward pressure on costs, that will result in access issues or other issues, just like we talked about earlier this morning. So there's going to have to be a strong consumer protection component of that. And I think that's you know, that'll be an interesting conversation, I think, with stakeholders, that flexibility is going to have to come with some stronger accountability. You know, aside from that, I don't know that this is really a trade-off, but you know, it's really important to have a holistic story going on with CMS and not just a laundry list of complaints. You know, we actually only have 7 regulations that are part of our waiver, even though our waiver is 300 pages, and so a lot of it isn't about here's 25 regs we don't like that we want to get rid of. It's really around, we want to get flexibility in a couple places, and we've got a pretty holistic story about how that's going to play out on the ground and what that's going to mean. And so that's pretty important. And you know, and I think the conversation with CMS constantly is, we understand why you want this flexibility, but why aren't you guys just doing it anyway? You know, and so they constantly kind of push on, are you sure you can't just do this through your contracts or through a state regulation change? So I don't know, Lori, any thoughts from you?
I think the other big area is around using Medicaid dollars to pay for social needs. So right now, the CCOs are certainly allowed to pay for what we call health-related services, which include community benefit initiatives. And they get those, they can pay those dollars, they get kind of credit in their medical loss ratio for those spends, but we haven't been successful in the first 2 go-rounds of our waiver in getting them counted as medical expense under Medicaid benefit. And so there's been lots of work. North Carolina made a lot of headway in their last waiver. And so they can invest in some of those things. So we're going to start there. And so I feel pretty confident that we can push that envelope, but that's going to be a challenge. The other one is, we have interest in when we were talking about people moving between systems, you know, is there some latitude, for example, to cover people who are just as involved while they're pre-adjudicated, so that we have the time for a warm handoff from their providers to make sure they have a supply of meds, and that the medical system within the jail, you know, knows what those meds are and that sort of thing. So, and that's been a real hard stop by Medicaid as well. So we do have some, you know, challenges, but I think, like Jeremy said, if we build a model of a delivery system that makes sense and that's not going to cost the federal government anymore and improve the health of Oregonians, then I think we have a good shot at moving a lot of this forward.
And Lori, let me ask, is there very little potential of moving houses and other support services under behavioral health integration and substance use treatment and mental health treatment? Seems to be the essential part of
you said the right things. I believe there is, that's where we want to look. When we talk about people with complex needs, we're thinking about those folks with behavioral and social needs. And that's where I think we can make the most headway on housing. We aren't going to be able to provide housing for all Medicaid members. I think that building bricks and mortar is probably not going to be on the table, but braiding funding, you know, we know that our state gets federal funding for that. How do we make that work for people who are, you know, experiencing homelessness, have chronic condition, some physical condition or behavioral health condition? Yes, I do think that we have an opportunity to make big strides there. Any other questions?
I just want to say, like, this is all really exciting, and I echo Brenda's comments about like how great this is framed, and it's really easy to follow. So I really appreciate all of that. One of the things that I'd love for you all to consider as you move forward with this work, this idea regarding like integrating like housing and behavioral health services into housing, and the idea of like layering federal dollars strategically, that's all really great. I think it can become very complex very easily, and therefore leave a lot of communities of color out of being able to engage in this, and really kind of allowing only mainstream providers who've already been doing this work for a very long time to continue to engage. So I'd really love for this idea around capacity building within culturally specific entities, providers, federally qualified health clinics, to get them to a place where they can actually also participate in these, just because I just know that can be very challenging for organizations who are still newer in this work or are still kind of evolving and emerging. The other idea too is thinking about like, how do these investments create economic opportunities, right? And how do we drive those economic opportunities towards BIPOC communities as well?
Yeah, thanks, Oscar. And we've definitely been talking a lot about community, more community control of some of the dollars as part of this, and making sure that the investments are really tied to where RHECs or other places are really seeing the challenges and the opportunities. So totally appreciate that.
Go ahead, John.
Well, I think this is just a terrific start. I really appreciate both slides, but then also the explanation of what do we mean by a global budget? Because there's all kinds of people out there saying the words global budget. And, thank you for putting a stake in the ground. And I would urge you to keep explaining that stake in the ground, and what is whether the CCOs and how they're defining it are consistent with your stake or not. And, what aspects would the state have in its budget? Your comments about inequity and the community investments, I think were really interesting. There's some controversies about that. I know there's quite a few mental health people who aren't quite happy that, their budgets have been put in with the CCOs. And so now they have to convince the CCOs to, put something back out there for them. But I think where you've gotten going here, from a global budget point of view, is really helpful. Second thing is, as I read this before, I was really bothered by over and over the document says access to coverage. It doesn't say coverage, it says access to coverage. And I think that's what you have to say because of all the eligibility issues here. And the degree we could get rid of all of the, as many of the eligibility issues, the administration, the unpredictability. I don't know, for example, is CMS considering how much this costs the delivery system to, have to grapple with all of these eligibility issues? Because of 770, I've gotten interested in, really where are the administrative costs? And oh my gosh, on the delivery system side, the administrative costs now of dealing with eligibility and payment and, fee for service are so enormous. They're so significant. And, getting rid of those somehow would generate enormous savings, I think. So I think somehow dealing, putting more stakes in the ground around eligibility and what you really want CMS to try and get rid of, and you know, reducing administration would be also be helpful. But this is a great start.
Yeah, thanks, John. And if we end up having 5 minutes still, I will try to cover the next section on eligibility and get to some of your points around that as well. But the way we've been thinking about it, although we don't have the solutions yet, is I think very much aligned with what you're saying, which is, you know, let's get folks in, let's keep them in, and that should be our goal, not making it difficult for them to have to keep, you know, not saving dollars because those who are eligible can't get in and stay in. Any other questions from folks before we move on?
You go ahead.
Okay, great. All right, well, good transition. So we'll now move into a little deeper dive on eligibility and coverage. And what we'll try to piece together here is this is connected to the 1115, but I think also a broader strategy of as the legislature's thinking about things like public option, cover all people, legislation to move the marketplace over to DCBS, a new federal administration that has told us they're really going to be focused on sort of stabilizing and building off the ACA. We think there's an opportunity here to really thread together several bodies of work into where do we really go as a state to get to universal coverage. Next slide. You know, this is clearly tied to OHA's mission around health equity and our goal around eliminating health inequities, and ensuring that all Oregonians can and all people in Oregon can achieve optimum health and well-being. You know, it's critical to have access to the healthcare system and to have access to affordable, high-quality care, and not just access to insurance theoretically, but actually are insured. So and making sure that insurance is actually affordable, so folks can use it and they can access the healthcare system. The health system is extremely fragmented, as you all know, between state and federal programs and self-insured programs that we can't touch, and so we have a system of coverage that's piecemeal between the state and federal government. But despite that, have made really, really large gains in getting to everybody having coverage. We've gone from 85% of the state being insured, and that being about where we were for several decades, to 94% pre-pandemic. We know we do a biennial health insurance survey, which will be out in the streets this year. So we'll have data on what happened through the pandemic. But pre-pandemic, there's a few things that we knew. First, about half of the 6% that are uninsured are actually insured at some point throughout the year. So they have access to some insurance at least part of the year, but then are uninsured for part of the year. We also know that about 3/4 say, based off of income, that they would actually be eligible for the Oregon Health Plan or the marketplace. And about 2/3 of those more leaning towards the marketplace. But we also know that the top reasons that folks are uninsured are because they lost OHP coverage, or they lost employer sponsor coverage, or they still say that it's too expensive. And so part of that is clearly an education issue. Part of it is probably enrollment challenges and eligibility issues challenge. And part of it is that folks might be eligible for some subsidies, but it's still not really worth it to them. It's still too expensive. And then we clearly know that there's a population of folks who aren't eligible for any of this because of immigration status, family glitches, some other kind of holes in the ACA, but the biggest one being immigration status. So we really want to start to thread together. Why don't we go to the next slide? We really want to start to thread together what can we do in the Medicaid space to really make sure that the folks who are eligible for OHP get in and stay in, as we just talked about. And that's really probably the extent of what the 1115 will do, but we want to couple that with other efforts that are happening. The legislature's made a big investment in Cover All Kids, and now all children in the state are eligible for medical assistance. It's looking like they're going to make an investment in Cover All People. There's, I think, really the debates around what's the size of that investment, whether it's what was in the governor's budget or something more. There's a separate conversation, John, that you're on around the task force for universal access that's been looking at how does how do we make some incremental steps towards getting towards universal coverage. The marketplace will be moving over, hopefully, if that bill passes, to OHA. So we want to think about really how do we couple 1115, what can we do with the marketplace, and then an investment around cover all people, and be able to take a more holistic story to the federal government and say, we think we could get from 94% to say 97 or 98%, and here's what we can bring, and what can you all bring as well. Next slide. On the 1115 side, waivers generally can adjust eligibility. This was a bigger issue before the Affordable Care Act, and when the ACA expanded to non-disabled adults. Before that, there was sort of a number of eligibility categories, and states would often kind of pick and choose those through waivers. The ACA really streamlined a lot of the eligibility to be based off of income. And Oregon historically has really maxed out whenever we can budgetarily. We've really maxed out all the eligibility categories that we can. And right now eligibility is largely based off of age, pregnancy status, disability, or income. And for folks on the ACA, which makes up probably about a third of the health plan, it's only income. Challenges come in really on the how do you do that calculation? When do you do that calculation? Largely folks, when they come up for redetermination, if they don't reapply, are basically booted out. So this is probably less about adding eligibility categories and more around the way we're doing eligibility. Can we make that easier for members? Lori, anything you want to add there?
I'll reiterate or kind of amplify the issue around eligibility. We know from the pandemic right now that we're bringing people onto the system and having them self-attest for income. It makes the process so much faster. And so we're looking at ways and that would require part of a waiver to say, well, we want to be able to continue to do that. And then we'll look at income later. And one of the key pieces on that is can we look at that at a broader window as opposed to the shorter window that we're required to right now. So that would be an example of the kind of thing that we could do for eligibility. The new eligibility system also has a lot more automated functions. So if somebody there's sometimes people can be enrolled passively. There's other times where people can just fill out the front page that says nothing has changed, and they don't have to fill out the 14-page eligibility document anymore. So I think it's a combination of making it easier for people to apply and get on, and then looking at how we can extend that time. Because like Jeremy said, likely if they lose eligibility because, like that person mentioned, one paycheck pushes them over the edge, they could go to the marketplace with huge subsidies, and the federal government's paying one way or the other. So how can we convince them to say, hey, keeping them on with their same doctors, their same health plan is a lot smarter.
Well, and if I can just add to that, it promotes continuity of care. If the care coordination work is being done right at the CCO level, you're not just intercepting them when they get sick, you're able to manage health better. And get a better return, a better outcome for them, better return, better use of resources for the system as well, by keeping people from bouncing on and off.
Next slide. So again, broader than just the 1115, but some of the challenges we'd like to try to address. We've talked about the churn on OHP, and that'll be the big piece for the 1115. The other piece of this, and we have to work through what we can really do, given that we're on the federal technology for the marketplace. But given that most of the largest percentage of folks who are uninsured and telling us they'd be eligible for a program would actually be eligible for the marketplace, but they aren't enrolling. And so I want to think through, are there things we can do on the marketplace side to go get those folks who are actually eligible, and the federal government's liable for covering their coverage, but they aren't in right now, and figure out that might be with the rescue plan that just passed, which it really expands marketplace subsidies. This might look more like an outreach campaign, but we want to think through, are there similar types of things we could be doing on the marketplace, again, within the bounds of what we can do with the federal technology to get folks in. The third bucket is folks who just historically been left out, and that's largely due to immigration status, and taking whatever investment we can get from the legislature and Cover All People, coupling that with services that are actually already covered under Medicaid for emergency services, and think about how do we really maximize some state and federal dollars to expand coverage to all Oregonians. And then I think the final piece is really how does a public option fit into this as well, which I see as Cover All People. I see as really filling in the cracks of folks who've been really left out of, who are low income, who've really been left out of subsidies for coverage. I think the public option is probably more targeted towards folks who might have insurance or theoretically are eligible, but it's still just not affordable, and coming up with a more affordable plan. So over the course of the year, we really want to kind of weave these together based off of what comes out of the legislature, and really be able to hopefully sit down with the federal government and say, can we kind of bring all of these pieces to bear and really move towards universal coverage, just to kind of give you, I think, an idea of how we've been thinking about this. We've already mentioned 200,000 more folks have come onto the Oregon Health Plan. Whatever they're eligible for post-pandemic, whether that's OHP or the marketplace, let's make sure that we don't drop them off and have those folks lose coverage, or our insured rate would spike pretty dramatically. Let's assume that we're kind of at 94% post-pandemic. The highest uninsured rate in the state in the country is Massachusetts at 97%. If we were able to stretch to get to 98, that's about 200,000 more people we need to find. So I think it's really kind of cobbling together a series of strategies that looks like, let's go find those 200,000 folks who many of whom are actually eligible, and figure out how to get them enrolled and keep them in. So why don't I pause there, see if there's other questions.
Jeremy, I'm waiting for someone to coin the term insurance hesitancy. So, questions or comments from the board?
I will just say there, the second highest category for why people are uninsured is just not interested. And I think that's, a lot of experts have said the highest you probably ever get as a state is 97, 98%. There's just going to be some folks who don't come in, but it feels like there's a big opportunity to really stretch ourselves and get there.
Kristen, you had a comment?
I just really appreciated the addition of this last bullet, so that there is a focus on not only like how do we expand coverage to people and get people enrolled in insurance, but also not lose sight of the problem of kind of underinsured folks or people who just can't afford to use the insurance that they have, and that someone is paying for them, that they or someone else is paying for them to have, but still it's unaffordable and they're not getting the care. So I really appreciated that combined acknowledgement. Thanks for the great work. This is really exciting.
Other thoughts, questions, compliments?
Hey, Jeremy, it's Tara. I just wanted to point out we have about 5 minutes left, and I believe there's a question on the next slide that we wanted to open up for member discussion. But of course, please take any other questions that members may have.
We'll get on the question. Can you go ahead, Michelle? Oh, here we go. Well, I think we're just going to end with reminding folks on the CCO 2.0 goals in those 4 areas, and just make sure that there's nothing that we've missed in this presentation today. Those 4 areas were around behavioral health integration, focus on value-based payment, pay for performance, social determinants of health equity, and financial accountability. So why don't we just end with any final comments? I saw some thumbs up. So is all feeling the right direction to folks, or anything that's clearly missing?
Jeremy, one thing you included in this is the importance of community input and community advisory councils, which is really, really important. Also in CCO 2.0, we talked about the input of local public health authorities, which I think is also is important to integrate.
Yeah, totally agree. And, we're trying to thread the combo of taking what we've heard from folks before, but also creating opportunities for others to weigh in through the Health Policy Board, and some general other input areas. So totally agree.
Jeremy, just a quick, earlier on in the discussion, something you all said, would the federal government let CCOs create a rainy day fund for the next pandemic, so that they would be likely more stable, that of course the state would highly regulate and hold them accountable for?
Lori, any thoughts on that?
It's a good question. We do have the CCOs hold reserves, but I think it probably would be a hard sell with CMS to have a large rainy day fund for a future pandemic.
And they would probably argue that the federal government has been dumping rain on the states for the last 9 months. And so what would you need that fund for?
Yeah, I think the bigger issue is probably less around the rainy day fund for CCOs per se, and more the issue of preparing for Medicaid budget a couple of years from now when the federal dollar is back down, which is what we saw in 2009, 2011. The match rates increase, which allows states to then invest in other places in their budget. But then when those match rates go down, as the economy improves, it creates a new hole.
Well, we're near the top of the hour. I apologize for my neighbor mowing his lawn right now, but wanted to thank OHA for a great presentation, the board for a great discussion. Also really appreciate the public comment at today's meeting. Next meeting, I'm going to take some COVID safe outdoor air vacation time, and Vice Chair Rana has agreed to chair the meeting. So I will miss you next month and look forward to seeing you again the following meeting. So thanks everybody, really appreciate your contributions and the collective discussion.
Thank
Well
you.
done.